Hello everyone.
How are you, Dr. Joshi sir?
Joshi sir, you are on mute, sir.
Ekdam fine.
Nice to see you.
Nice to see you. Nice to see you.
So Rohit, another 5 minutes we will start.
Sure.
Welcome all the chairpersons, and then over to you.
Yes.
You're going to share from your laptop, right?
Yeah. Yes. So we will have a 6 minutes video followed by a 2 minutes discussion.
Yes.
Okay.
Absolutely. How many are we going to showcase?
5 videos and 6 free papers.
Super. Fantastic. So we have at 3:30 we have to give it to the next session on statistics.
Yeah.
Yeah, Joshi sir saying something?
Video will be first or free papers?
We are alternating, na?
Alternate.
Yeah, we are alternating. So it's to break the monotony. Thoda video, thoda free paper.
Yeah. Always better.
Yeah.
प्रीतम सर आपण ते हॅलो बॅकग्राऊंड जे आहे व्हर्च्युअल बॅकग्राऊंड दिलाय का आपण स्पीकर्सला?
हो सर, ते आपल्याला ईमेल केलेलं आहे सर.
अच्छा, ईमेल केलेलं आहे. बरं.
हो सर, आपल्याला ते ईमेल आला असेल.
बरं.
माझ्या याच्यामध्ये ते व्यवस्थित दिसत नाही.
हा बरोबर, तो ब्रेक होतो, फेस ब्रेक होतो बऱ्याच वेळा. फेस म्हणजे हात असा वरती केला की काहीतरी असं वेगळं.
It's just 2 o'clock, 1400. So let's start.
Yes.
So I, Dr. Preetham Samant, Scientific Chairman, would welcome everyone to this a milestone in the history of Maharashtra Ophthalmological Society, the MOS Virtual Conference First 2020. And we today are the opening batsmen. We are starting the conference. This Hall C, the first session is on the award-winning papers and videos of 2020. I would like to invite my co-chair for this session. I would like to invite Dr. Sunaina Malik Madam, Dr. Parikshit Gopte Sir, Dr. Vardhaman, Dr. Rohit, the Secretary of the Scientific Committee. In a milestone event for MOS, the free papers and videos that were submitted for 2020 were presented and judged live on a virtual platform on last Sunday, 1st November. And they were given marks and scores. And this session today will showcase all those free papers and videos which got leading scores and were highly appreciated by the audience. Now, I have just two instructions before I ask Dr. Rohit to take over. Number one, all those who are with me on as the presenters and the chair people, I would like them to switch off their audio when any presenter is talking. So when you switch off your audio, that way there is no background noise and all of us can hear the proceedings properly. My second advice is to all the presenters, remember today we are not judging. There are no marks today. Okay, so speak your heart out, tell openly, discuss openly your free paper and your work. This is the chance you will get. So the pattern will be following. Rohit will explain the pattern. So without further delay, you Rohit, please take over and conduct the session.
Thank you, Preetham sir, for your kind introduction. Today we are going to have the top 6 free papers and the top 5 videos which were submitted for the MOS Virtual Conference 2020. We will be alternating between the free papers and the videos. Each presentation would be of 6 minutes that would be played from my side and followed by a 2-minute discussion. So first, I'm going to present Dr. Rajesh Joshi's work, A Big No to Sticky Visco. Is the screen visible?
Yes, we can see the screen.
Hello friends. After routine cataract surgeries, post-operative surprises are not uncommon. On post-operative day 1, sometimes I get really annoyed due to post-operative rise of IOP and inflammation caused by retained viscoelastic. If visco is the culprit, can we use only BSS for the surgery? Here we present our technique of viscoless phaco. Say a big no to the sticky visco. It is important to keep the anterior chamber maintained throughout the surgery. That is why side port entry is crucial. We prefer MVR blade for side port, which is removed quickly to prevent collapse of anterior chamber. We routinely use Trifam blue to stain the anterior capsule. To illustrate how visco behaves during various steps of cataract surgery, we deliberately stained a viscoelastic with Trifam blue, and we observed it is impossible to remove viscoelastic from the anterior chamber in toto. Continuous irrigation is used through the left-hand side port to maintain the anterior chamber and to stabilize the globe during main port entry by keratome. Here comes the real challenge of viscoless phaco surgery, the capsular axis. After stabilizing the globe with left hand, microrhexis forceps is used to perform the capsular axis, keeping in mind turbulences and fluid currents of continuous irrigation in the anterior chamber. Hydrodissection is performed routinely. During nucleus management, first insert the phaco probe with irrigation on and later replace the chopper in left hand. If the phaco energy uses, direct chop was used. Nucleus was divided into fragments and they were emulsified. For irrigation and aspiration, chopper was removed first, which was replaced by irrigation probe, and then the phaco probe was removed. Through the side port, aspiration port was introduced, and then the IF was carried out. After the completion of cortical removal, IOL was inserted in the bag under the irrigation. IOL was rotated gently inside the bag with the help of dialer. Start hydrating the ports before removal of irrigation cannula. Friends, let us see how difficult it is to remove viscoelastic completely at the end of the surgery. Blue flecks seen here are retained visco. Now I am fully ready to say a big no to the sticky visco.
That was a great video, Dr. Rajesh Joshi, sir.
Yeah, thank you, sir. Thank you.
Yeah, I would like to invite Dr. Malik, madam, who has just joined, and Dr. Parikshit, sir, who has just joined the chair. Welcome, madam. Welcome, sir. I just mentioned, Dr. Joshi, sir, I'm sure you've done cases with visco and those with BSS. So have you compared your results in terms of, the endothelial count or some objective way of knowing, whether it has made a difference?
Yeah, in fact, at our center, we don't have a specular microscope, but we compared corneal thickness with and without visco. And we found that, in fact, there was no statistical significance between both these methods. But as far as inflammation is concerned, definitely inflammation is less in BSS as compared to viscoelastic.
Rajesh, can I make a point? In order to make your your video more statistical, I think you would need to have specular microscopy so that there can be a definite difference seen between cases done with your method and the other method.
Definitely, I agree with you, but being a video and not a paper, that's why
Yeah.
we thought.
But this can be presented as a paper also, later on.
Right.
So
Absolutely.
just a small suggestion.
Thank you so much. Thank you.
Thank you.
Great. Fantastic video. So Rohit, shall we proceed? Can we go to the next one? Thank you, Dr. Joshi.
Yeah,
Thank you, sir.
Yeah.
absolutely. So that was a fantastic video by Dr. Rajesh Joshi. Moving on to the next, we are going to have a free paper. It is titled Visual and Anatomical Outcome in IOP Removal by Dr. Fatima Nobel.
Just a quick point again to all our people who are on the chair today, that to please keep your audio off when when we are playing or the person is talking, so that will give us a crisp audio. Thank you.
Is the screen visible?
Yes.
Yes.
One second. So sorry. Fatima, you are present the meeting, right? So I will move these slides. You can give the voiceover because your voiceover is not functional.
Yes. Yeah.
Okay.
Is she there? Dr. Fatima is there.
Yeah, I can see her. Fatima, can you unmute yourself? Okay, we are not able to connect to Dr. Fatima. We'll move on to the Fatima. You're there.
See her. If that is her. F.
Yeah. Hi. She's there. Yeah.
Yeah. Yeah. So you can give the give the voiceover yourself and tell next so that Dr. Rohit can move the.
Yes, sir. Okay, good afternoon, everyone. Myself, Dr. Fatima Noble. Thank you, MOSVIRCON, for giving me this opportunity. I'll be presenting on visual and anatomical outcomes in IOFB removal. Coming to the case scenario, a 35-year-old male with a history of injury to the right eye while working was diagnosed with full thickness corneal tear on anterior segment and indirect ophthalmoscopy suggestive of intraocular foreign body, which was later confirmed by CT scan. As relatives and patient were anxious about the visual prognosis, so I went through some literature and decided to do a detailed study on the prognostic factor in case of intraocular foreign body removal. So next slide. So next. My study included 46 cases of intraocular foreign body, which were reviewed, one behind. So one slide behind. My study included 46 cases of intraocular foreign body and posterior segment, which were reviewed retrospectively from 2014 and 2019, with demographic data included age, sex, entry site, and time between injury and repair. The mean age came to 33 years with a mean follow-up coming to 9.4 days. The next slide. I included all the patients with history of intraocular foreign body with trauma. I excluded patients who had a previous surgery, except cataract surgery, any pathology which was affecting vision, and of course, patients who did not give consent for the study. In my study, out of 46 cases, 7 patients underwent 23 gauge vitrectomy with IFB removal. 15 cases underwent 23 gauge vitrectomy with IFB removal and lensectomy, and 23 with 23 gauge vitrectomy, IFB removal, lensectomy, and intraocular implantation, lens implantation. And maximum 26 patients had silicone oil as internal tamponade. The next slide. So can you just play the animation?
Yeah, it just give me a second. Yeah, this one.
Yes. My cases had association with corneal tear, cataract, endophthalmitis, retinal detachment, and vitreous hemorrhage. The next slide. Coming to the entry wound, patients who had an entry wound through cornea had a poor visual prognosis than the patient who had an entry wound through the sclera. The next slide. Coming to the site of the lodgement, patients who had an intraocular foreign body lodged in the retina had a poor visual prognosis than the ones who had an intraocular foreign body lodged in the vitreous cavity. The next slide. Coming to the type of foreign body, patient who had a metallic foreign body had a good visual outcome than the patient who had a non-metallic foreign body. And size of the foreign body, patients who had a foreign body more than 4 mm had a poor visual prognosis than the ones having a foreign body less than 4 mm. All the cases were associated with 100% endophthalmitis, 53.3% had cataract, and 69.2% had corneal tear. So coming to the time interval between the trauma and surgical intervention, it was earlier thought the more early you do a surgery for intraocular foreign body, the better will be the prognosis because you are avoiding endophthalmitis. But now it has been studied that if it's a metallic foreign body and if you delay it for some time, it will reduce inflammation and you can handle it well. So there is a controversy in this. Coming to the visual outcome, the overall logMAR improved basically after intraocular foreign body removal. The next slide. In our study, it was found out that the young male industrial workers were at the greater risk in this study, and the outcomes depended upon the size of intraocular foreign body, the site of lodgement, the entry wound, the endophthalmitis, and type of intraocular foreign body, with non-metallic having a worse visual prognosis. So basically, this study helped in finding out the severity of trauma, determining an appropriate treatment for the patient, and predict the visual prognosis. Thank you.
That was a nice presentation, Dr. Fatima. Fatima, did you all study the microbiological profile of your cases?
Yes, sir, we have studied, like depending the organism, but it's not included in this free paper.
Any questions for Dr. Fatima from any of our panelists? Or did you have any sympathetic cases, sympathetic ophthalmia? Did you see perforating injuries that can happen?
Yes, sir. Yes, sir.
Did you have any of them?
So 2, 3, but I have not done a detailed study on that.
Okay. Okay. Thank you.
Thank you, sir.
Dr. Rohit, shall we proceed to the next one?
Yes, definitely. So the next is going to be a video presentation, All Roads Lead to Rome, Macular Hole Surgical Techniques by Dr. Sumitra Nagare.
38-year-old female came to the OPD with complaints of diminution of vision, visual distortion, and dark spot in central vision since 1 week. On examination, visual acuity was 660, fundus showed central round lesion at macula, and OCT showed full thickness defect at fovea, hence diagnosed as macular hole. It is defined as a full thickness defect in the neural retina, concentric on the fovea. Based on OCT, modified gas classification shows stage 1A small central yellow spot, 1B yellow ring with loss of foveal depression, stage 2 showing small full thickness macular hole of 100 to 300 microns, stage 3 showing full thickness macular hole of 350 to 600 microns, and stage 4 same as stage 3 with posterior vitreous detachment. In an asymptomatic patient, due to 50% chances of spontaneous resolution, observation is preferred in stage 1 and few stage 2 cases. For rest all, surgery is the preferred mode of management. The first successful macular hole surgery was published by Kelly and Wendell in 1991. These are the basic steps in a macular hole surgery. After core vitrectomy, PVD induction is done, which is important to reduce traction on the macular hole. ILM is stained to ensure proper peeling using dyes like brilliant blue, Triffin blue, and indocyanine green. In the pinch technique, ILM is pinched with forceps and gently pulled away from the macular hole margin. In flip the flap technique, a small incision is given over the ILM away from the macular hole margin. Then the ILM is held with the forceps and pulled as a flap. In conventional peeling, the ILM is peeled centrifugally as a tangential vector, regrasping the ILM every few degrees of the peel. Inverse ILM peeling was first described by Makalewska et al. In 2010. Here, ILM peeling is started centripetally about 100 microns from the edge of the hole and interrupted at 500 microns from the center. The remaining ILM is peeled in conventional manner. The ILM is then gently massaged over the macular hole till it gets inverted. In reverse ILM peeling, the ILM peeling and flap preservation on the macular hole edge is similar to the inverted flap technique, but the preserved ILM flap is plugged into the macular hole, which acts as a scaffold for faster anatomical closure. ILM peeling can also be done using the scraper technique. Fluid gas exchange is done in a controlled way to prevent flap displacement using gases like C3F8 and SF6. Post-operatively, 3 to 4 weeks of strict prone position is maintained. Other techniques such as the use of heme plug, visco plug, and autologous concentrated platelet and thrombin plug have also been tried. Use of ocriplasmin injection is a non-surgical method used for vitreomacular adhesions. For refractory cases, autologous lens capsular flap transplantation with autologous blood application and absorbable macular plug can be used. In case of simultaneous retinal detachment of macular hole, utmost care should be taken to stabilize the retina. This can be achieved by injecting PFCl prior to ILM staining. In addition, PFCl also prevents the dye from gaining access to the subretinal space. If we are unable to use PFCl, the dye can be injected away from the macular hole.
Yeah, so those are good videos, Dr. Shruti, right? Who presented it? Rohit?
Dr. Sumitra and Tagare.
Okay. So just to make a mention here that, this when chromovitrectomy first came into vogue with indocyanine green, actually, ICG was first used to stain the ILM. But certain studies showed that ICG was a little toxic to the retina. Probably ICG made even the ILM brittle, and that's why it facilitated the removal. And some electrophysiological study did show that it was toxic. So I think ICG was then replaced by Brilliant Blue G. The BBG is an excellent dye, has proven to be not toxic. So that is what we use for ILM peeling. This was a wonderful video. Any comments? We have Dr. Santosh Agarwal here with us. I can see him. Santosh sir, any comments on that? Dr. Santosh Agarwal, a very accomplished retinal surgeon with a lot of innovative techniques he comes up with. Santosh sir, your comments?
Yeah, it's an excellent video. I actually last few techniques I could see, and it's really Brilliant Blue is very amazing. It gives staining, and we can perform in whatever way you are comfortable with the technique. And I think inverse flap technique is very good technique. And I have no experience with the capsular piece or any other method, but whatever I am doing, I got excellent result with that.
Thank you. Shall we proceed then, Rohit?
Yeah, absolutely.
Thank you, Dr. Sumitra. Thank you for the presentation. Let's proceed.
Thank you, sir.
Yeah, I welcome Dr. Prashant Bhavankoe, sir. He has just joined us.
Welcome, so next we have a retrospective multifactorial study of pediatric infectious and non-infectious keratitis in South India by Dr. Abhijit Tagare.
Dr. Jagannath Buramani sir has joined us on the panel. Welcome, Dr. Buramani sir.
Yeah, thank you very much.
Is the sound audible?
Yes, we can hear you, but is there a voiceover?
There is a voiceover. I guess the voice is very low.
Okay, so if the presenters are here, then they can take over.
Do we have Dr. Abhijit Tagare with us? He is not there with us. I'll move on to the next.
And come back to his presentation later. Yeah.
Absolutely. So we can have one of the amazing free papers by Dr. Prashant Bhavankoe, comparative study of success of various techniques of ILM peel in management of rheumatogenic retinal detachment with PVR with macular.
Are you sharing your screen, Rohit?
Yeah, I'm doing that right. Sir. Just give me a second.
The incidence of retinal detachment with concomitant macular hole is 2.5 to 4% in various studies and majority of this have associated PVR, that is almost 53 to 67%. Macular hole develops either because of posterior vitreous pool as it happens in peripheral hole or because of a tangential traction. ILM peel and thereafter inverted peel has further increased the success rate of FTMH in attached retina. Would inverted peel add to improved success rates even in a detached retina was the question. The aim of our study was to assess the anatomical and functional success in patients with RRDs with proliferative vitreoretinopathy equal to or more than C1 with coexisting macular hole using different management strategies. Patient underwent standard study. This is a prospective non-randomized observational study of 23 eyes of 23 patients. These patients were subdivided into 3 groups. Group 1 had pars plana vitrectomy without ILM peel. Group 2 had a ILM peel, while Group 3 had a inverted ILM peel. Patients underwent standard steps of 23 gauge vitrectomy without encirclage with silicone oil as tamponade. ILM peel was done in Group 2, while inverted ILM peel was done in Group 3. In no peel group, out of 6 patients, 3 patients had attached retina, while in ILM peel group, 1 had recurrence out of 10. In inverted flap technique, all 7 patients had attached retina at 3 months post SOR. KM plot shows significant p-value of 0.029, indicating significant reduction in recurrence in a ILM peel as well as inverted flap group. One case each in no peel and ILM peel group had recurrence because of peripheral PVR changes. Recurrent macular hole was noted in 2 cases of no peel group, of which one had recurrence only because of reopening of the hole with no peripheral retinal break, while one had associated peripheral break. When we look at the visual acuity gain in 3 groups, maximum gain was noted in inverted flap group, though it did not achieve statistical significance. This is a representative pre-op OCT of a patient of retinal detachment who was diagnosed to have associated macular hole, while intraoperative photographs are of patients whose macular hole was noted during the surgery. The post-op OCTs at 1 month in various groups are demonstrated here. So to conclude, better macular hole closure and attachment rates can be achieved with inverted ILM flap technique. Visual acuity gain is seen more in inverted ILM peel group compared to no peel group. Though challenging and not free of complications, inverted ILM peel can be considered as a procedure of choice in these cases. The limitation of our study is that it has a small sample group. Definitely large randomized studies are needed to confirm the better results with inverted ILM flap technique in this subset of ligmatogenous retinal detachment. Thank you.
That was a wonderful paper, Dr. Prashant. I just had a question. In your series of these RDs with macular holes, how many of them were related to trauma, post-traumatic? Because when you look at a trauma etiology, you're always sometimes prognosis may not be that good because of probably a choroidal rupture underneath.
They were excluded in the study. Trauma
Okay.
and
So these were spontaneous reg RDs with macular holes.
more than C1 grade. Hello.
That was a great free paper. Thank you, Dr. Prashant.
Thank you.
Yeah. Let's move on to the next one, Rohit. Which one do we have next now?
So the next we have a wonderful video by Dr. Santosh Agrawal of an innovative phacochore.
Okay. Again, for all our audience and panelists, I would like to say that these are all videos and free papers which made a great impact on last Sunday on our judges and our the people who attended. But we are still in the process of computing the marks and scores, because there are total of 13 categories under which we will be giving the awards for these free papers and videos. So we will take a day or two more to actually compute the scores and come up with the awards. Yeah, please go ahead. Let's start.
I am Dr. Santosh Agrawal. I am going to present the video on an innovative visco chopper through which the visco can be delivered inside the entry chamber. It acts as a two-way function. One, it acts as a chopper and also as a visco delivery system. So this is applied to the silicone oil port or the vitrectomy port on the console, and the silicone oil system is used for this purpose. Instead of silicone oil, we use visco, and this is the knob on the foot pedal which is given by the company for activation of this port. You can see the VAPI port on the console, which is specially made for this purpose by TurboVit Appasamy machine. And this is a challenging case, white cataract. The intracapsular pressure is very high, so it is very difficult to perform the CCC in such cases. And as the visco is delivered as and when necessary, you can make the entrechamber deep, as well as you can see the peripheral extension of CCC can happen at this moment. So we can inject the visco at this moment and we can avoid this peripheral extension of the CCC. This is the intumescent cataract. We are extracting the liquid cortex from the capsular bag through the tiny opening, and one is injecting one port. Through one port we are injecting the visco through a automated visco delivery system, so we can take out the fluid cortex. At the same time we can inject the visco. Now this is the PC rent which has taken place, and to avoid the extension of the PC rent, we can inject the visco inside the entrechamber through this chopper, so that the entrechamber depth is maintained, IOP is maintained, and the visco will take care of PC rent and the vitreous. Now this is the small pupil. Again, it is very difficult to perform the CCC, so visco can be delivered and you can have CCC with ease. This is another case of hypermature cataract challenging situation. Here I used AC maintainer to deliver the visco. It can maintain the entrechamber, and you can extract the fluid cortex, the liquid cortex, through the main incision or through the extractor. This is another challenging situation where the last piece of the nucleus, while removing you need good AC depth, otherwise PC rent can happen. This is another challenging case of lens induced glaucoma case. Corneal edema is there, iris is coming out through the wound, lot of IOP pressure in spite of all measures. We have taken anti-glaucoma measures. So this visco inside the entrechamber can give you protection from the endothelial damage. This is another scleral fixation IOL case where a lot of manipulation is required, and the chances of hypotony is there. So to avoid that, through AC maintainer, visco is delivered inside the entrechamber and the IOP is well maintained. Pediatric cataract case, the CCC is very difficult because of obvious reasons: elastic capsule, less rigidity, scleral rigidity. So to maintain the IOP and entrechamber depth, visco is delivered through the AC maintainer. This is a hard cataract, supra hard cataract. Endothelial damage can happen in routine cases, but with the help of visco, you can avoid that. And this is the manual way of delivering the visco inside the entrechamber through the visco chopper. And initially I showed you the automated technique. So this helps in a complicated cataract cases, phaco cases, to deal with the endothelial damage, to maintain the AC depth. The manipulation are easy and to perform, and the PC rent also can be managed very well, and we can avoid the PC rent in most of the cases. This is the silicone oil system which we have utilized for this purpose, and especially visco chopper is made by a 26 gauge needle, and the special handle is made by the company. Thank you very much for your patient listening.
A very nice video, Dr. Santosh.
Thank you, sir.
So what are the pressure settings which are used on that machine when you're injecting the visco?
Actually, that company has given me around 100. So I feel it is less, but it suffice in most of the cases. I ask them for a little increase in the pressure. Many times through the 26 gauge needle, it is very difficult to inject the visco. So nowadays I started using 24 gauge needle for the same purpose. So I get the visco as and when necessary. In complicated phaco cases or hard cataract cases where we need endothelial protection, in such cases, or to avoid PC rent and to have a good depth of AC, I think this is the most rewarding technique. And also many cases, if you get a PC rent, if you take out your phaco probe, you get extension of the PC rent. But in such cases, we can inject at the same time the visco inside the antechamber, and we can avoid the extension of the PC rent. So it is very useful technique, and each and every cases nowadays I am using this technique. But for the most of our phaco surgeons in difficult cases or in hard cataract cases, definitely it is very useful. It acts as a third hand actually.
We have also there is as retinal surgeons, we even talk about visco dissection of membranes from the retinal surface. Probably even such an instrument or technique can probably help over there also.
Definitely, yes.
Yeah. But wonderful technique, wonderful innovation, Dr. Santosh. Thank you so much.
Thank you, sir. Thank you.
So we move on to the next paper video. Rohit.
Yeah. So the next paper is by Dr. Shruti Ladha. It compares the OCT angiography versus structural OCT. Dr. Shruti, can you give the voiceover? When you say next, I'll move on to the next slide.
It's a self-running presentation, so it will run and I'll do the voiceover.
Okay, ma'am. Thank you.
Okay. Good afternoon, everyone. I'll be presenting today on comparison of documenting the treatment response to anti-VEGF in wet AMD. OCT angiography versus structural OCT. Myself, Dr. Shruti Ladha from Shanti Saroj Netralay, Meerut. As we all know, OCT angiography is a novel, non-invasive technology that rapidly images the blood vessels in vivo. Studies have shown that OCT angio is a significant tool to document the CNVM and monitor its response to anti-VEGF. But none of these studies have simultaneously compared the ability of structural OCT and the ability of OCT angio in documenting the treatment response to anti-VEGF in wet AMD patients, particularly in Asian population. So the question arises, if structural OCT is available, do we really need OCT angio for documenting the treatment response? The purpose of our study is to determine the ability of structural OCT versus the ability of OCT angiography in documenting the treatment response to anti-VEGF injection in wet AMD patients. We conducted a retrospective study in which 40 eyes were recruited over a period of 10 months. Heidelberg spectralis was used for both OCT angio and structural OCT. 40 treatment naive eyes with active CNVM wet AMD were selected. Baseline OCT angio and structural OCT were done for all these patients. 3 intravitreal anti-VEGF bevacizumab were given monthly. and monthly monitoring of treatment response by OCT angio and structural OCT was done for all these patients. For evaluation of treatment response, structural OCT criteria were reduction in subretinal and intraretinal fluid, reduction in height of PED, reduction in number of hyperreflective spots. The above image is of structural OCT prior to giving anti-VEGF injection, where we can see there is evident intraretinal and subretinal fluid, subretinal hyperreflective material, and the CNV complex. The below image is of 1 month after giving anti-VEGF injection, where there is evident reduction in intraretinal and subretinal fluid, reduction in the subretinal hyperreflective material, thus reduction in CNV activity. OCT angio criteria for treatment response were reduction in area of neovascular complex, reduction in number of anastomotic vessels, and conversion of immature to mature vessel configuration. Here, the first image is of OCT angio prior to giving anti-VEGF injection, where the CNV complex area is 3.22 mm square. 1 month after giving anti-VEGF injection, there is a reduction of CNV complex area to 1.88 mm square, as well as we can see there is evident reduction in anastomosis and conversion of immature to mature vessel configuration. Following were our exclusion criteria: non-EMD CNVM, other ocular disease which can alter the interpretation, example associated hypertensive or diabetic retinopathy, inability to capture a good quality image, example in macular hemorrhage. We found that structural OCT detected signs of treatment response in 36 out of 40 eyes, that is 90% cases. Whereas OCT angio detected signs of treatment response in 37 out of 40 eyes, that is 92.5% cases, which is almost similar. Statistical analysis showed that there is no significant difference in the ability of structural OCT and the ability of OCT angiography in documenting the treatment response to anti-VEGF therapy. So coming to discussion, here we can see in recent year, few studies published in some established journals have emphasized that OCT angio is a very important tool for monitoring the treatment response. But none of these studies have simultaneously compared OCT angio and structural OCT. In our study, with comparatively larger sample size, we found that there is no significant difference in OCT angio and structural OCT in documenting the treatment response to anti-VEGF therapy. So the conclusion of our study, though OCT angio was more sensitive compared to structural OCT for documenting the treatment response to anti-VEGF injection, the difference in sensitivity was not statistically significant. Here are my references. Thank you.
I think that's a very good original work done, Dr. Shruti.
Thank you, sir.
Yeah, I'm sure you had a guidance of your able senior Dr. Sharad Bomaj with whom you're working.
Yes, sir.
So I think both these investigations have a place of their own, because both these investigations essentially are based on two different techniques. Whereas one, the OCTA itself looks at the flow of blood vessels to the retinal vasculature. The OCT is essentially a structural scan of the retina. So
Yes.
and then FFA has its own place, which actually shows the function of the endothelium and the blood retinal barrier. So all these three investigations have their place of their own. You've done a good study to really see whether they have an impact on a practice or no, because all these investigations, economically they cost so much.
Expensive.
So,
Yes, sir.
yeah. So any comments, Rohit, from your side? Rohit
I
has,
feel it's a fantastically beautifully done study, and it is quite clinically relevant, especially in the current scenario when the investment in retina is quite huge. So whether it is prudent to invest in OCTA, I think so that question is to some extent answered by this paper.
Great.
So
Thank you, Dr.
next,
Shruti. Thank you. Let's proceed further, Rohit, to the next
So
one.
the next is a video presentation on phaco slice by Dr. Sanjay Dekawade.
Dr. Sanjay, welcome. Let's start.
Of phaco slice as an alternative to chop for better nucleus management. We do not have financial interest in this video. Chopping is difficult in soft, hard and brittle cataracts. Here, with the help of a special instrument, slicer, we hold the nucleus and slice it into small pieces and subsequently emulsify. The instruments on the right hand side is a regular chopper and this is a slicer like a sickle horizontally oriented. Soft cataracts pose a special problem as it is difficult to firmly hold the fragile nucleus and chop it by a regular chopper. We hold the nucleus and slice it horizontally and then aspirate or emulsify the small fragments. Notice the major portion of the nucleus is firmly held back into the capsular bag by the slicer, thus protecting the posterior capsule all the time and preventing the fragments to shatter in the anterior chamber and cause damage to the endothelium. The slicer also manipulates and reorients the nuclear fragments to the phaco tip, thus preventing chasing of the nuclear fragments, keeping the probe all the time in the center. This horizontal slicing protects the endothelium and the posterior capsule, as you can see here. Next, we present a posterior polar type cataract. Here, it is again difficult to chop the fragile nucleus. After the CCC, we do a gentle hydro delineation as seen here by the golden ring. As you cannot rotate the nucleus, the central portion is first tackled and then gradually we move towards the mid-peripheral nuclear portion, finally the epinuclear part, and then once the whole nucleus and the central hard core is sliced and emulsified. Here you see the second half of the nucleus being sliced and emulsified piece by piece. Notice how the slicer holds back the piece in the bag, protecting the posterior capsule all the time. We need not change the parameters for the last piece as the slicer is oriented horizontally and it prevents any damage to the posterior capsule during any surge. The third case is an advanced white on brown hard cataract. We hold the nucleus and slice the pieces into smaller fragments and emulsify. You can notice the leathery type of the nuclear fragments, which is difficult to chop by the regular chopper. The slicer not only slices but separates the fibers easily because of its sharp inner edge. We take the fragments one by one and emulsify it in the center, thus protecting the posterior capsule and the endothelium. At the same time, the slicer feeds the nuclear fragments into the tip of the phaco probe, minimizing the use of phaco energy inside the eye. Here you see the final fragment being sliced and emulsified. Finally, we present a white, intumescent, brittle cataract, wherein it is difficult to hold the brittle nucleus and chop with a regular chopper. After completing the capsulorhexis, which sometimes is difficult in these cases, we hold the nucleus with the phaco probe, and with the slicer in the left hand, we slice small pieces and emulsify them in the center. Here you can see each piece being gradually sliced and fed into the phaco probe. This prevents chattering of the fragments and keeps the remaining part of the nucleus firmly into the capsular bag till the end of the procedure. See the ease with which the fragments are being sliced requires very minimal energy, which is friendly to the endothelium. These type of cataracts have very minimum epinuclear cover, so a horizontal instrument is friendly to the posterior capsule in case there is any surge.
Fantastic presentation, Dr. Sanjay. So this instrument was designed by you, sir?
Yes, we have designed it ourselves. We have got it manufactured by one of the suppliers, but it is not commercially available.
I would definitely suggest that you should get a design patent for it. There are many firms which are providing it at a minimum cost.
Right.
You've done a fantastic job, sir.
Yeah.
So,
thank you.
Do you face any complication in terms of PC rent? I saw that design is beautifully made to actually protect the PC.
Right.
Any problems faced?
Yeah, in fact, why I designed this was because the regular chopper, many times when you get a surge, the regular chopper is to inadvertently damage either the posterior capsule or sometimes the anterior capsule. Whereas in this design, if you see, it is sharp only on the inner side, which doesn't get in contact with anything. The outer circle or the outer C is totally smooth. So, and being horizontal, even if there's a surge, it will just, like a repository, it will touch it, but it will never rupture the posterior capsule. At the same time, you will not inadvertently cut the anterior capsule also.
Yeah, fantastic work, sir. Thank you. Thank you very much for sharing your amazing technique.
Thank you. Thank you very much.
So next we have Dr. Abhijit Tagare online. I would request Dr. Abhijit to give voiceover for his presentation. I will be sharing the presentation from my side.
Hello, sir.
Is the presentation seen, sir?
Yes, we can see it, Rohit.
Yeah, please.
We can see it. Yeah. Hello, Dr. Abhijit.
Yeah, hello, sir.
Please. And thank you to Dr. Sanjay for the wonderful previous presentation.
Thank you.
Dr. Abhijit, we can start now, please. Dr. Abhijit, I would request you to give the voiceover for your PPT, and you can ask me to move on the slides.
This is not. Sorry. So, hello. One second. This is 1 second, sir. Hello, sir. One second, sir. 1 second.
Dr. Abhijit is facing some technical glitch. We will move on to the next free paper. We will come back to his free paper in some time. So the next free paper.
He has unmuted you. He has unmuted.
So the next free paper is going to be by Dr. Priyanka Kanikar, study of efficacy of rivapamide 2% and carboxymethoxylase 0.5% eye drop in dry eye cases.
Respected everyone, myself Dr. Priyanka Kanekar and my paper topic is study of efficacy of ribamapide 2% and carboxymethyl cellulose 0.5% eye drop in dry eye cases, co-authored by Dr. Rupa Naik and Dr. Siddharth Sane. Background and objectives. Dry eye disease is a tear film disorder which causes ocular symptoms like foreign body sensation, dryness, blurring of vision, photophobia and tear film dysfunction. The prevalence in India is 29.25%. The primary causative reasons of dry eye are lack of tear production or increased tear evaporation which causes deterioration of the ocular surface and is associated with symptoms of ocular discomfort. Ribamapide is a mucin stimulator drug. It helps in cytoprotection, healing of wound and has anti-inflammatory and free radical scavenger properties. Carboxymethyl cellulose is the most frequently used drug as the artificial drops in dry eyes. CMC prolongs the retention time, duration of activity, lubrication and hydration of ocular surface. The current study was conducted with an aim to assess the effectiveness of 2% ribamapide and 0.5% CMC eye drops in the dry eye. Materials and methods. It was a randomized interventional prospective study done from January 2019 to December 2019. Sample size 40 in each group, that is total 80 patients were chosen from outpatient clinic of ophthalmology department of a tertiary care hospital. Data was analyzed using software EpiInfo version 7.2. All results are expressed as number, percentages and mean plus or minus standard deviation in the form of tables and graphs. Mean values of scores was compared using unpaired t-test. A value of p less than 0.05 is considered significant. Inclusion criteria. Patients with score of more than 2 for one or more dry eye related ocular symptoms for more than or equal to 2 months, Schummer's 2 test value less than 5 mm at 5 minutes or tear film breakup time less than 5 seconds, patients willing to participate in the study and who are ready to give written informed consent. Exclusion criteria. Patients with active eye infection, known allergies to ingredients of the 2 drugs, using contact lenses, blepharospasm, glaucoma, punctal plug, vascular disease, history of ocular surgery within 1 year and history of any ocular medications which causes dry eye. Total 80 patients with dry eye disease fulfilling inclusion and exclusion criteria were selected and they were divided into 2 equal groups, such as Group A included 40 patients which received ribamapide 2% and Group B included 40 patients which received carboxymethyl cellulose 0.5%, 1 drop in each eye 4 times a day for about 3 months. The following parameters were evaluated: distant visual acuity, anterior segment slit lamp examination, tear film function by tear film breakup time, tear secretion, Schummer's 1 and Schummer's 2 test, slit lamp examination of tear meniscus height and IOP measurement by Goldman's applanation tonometer. Follow-up. Patients were assessed at 4, 8 and 12 weeks. Results and observations. Table 1 shows demographic data. There was no significant difference between the 2 groups since the p-value is more than 0.05. Comparison of mean Schummer score. In the follow-up period after treatment with drugs at 4 weeks, there was no significant difference in the mean Schummer's test score between ribamapide and CMC groups. In both the groups, Schummer's test was found to increase gradually from 4 weeks to 12 weeks. At 8 weeks and 12 weeks, Schummer's score was significantly more in ribamapide 2% group than CMC group, p-value less than 0.05. Comparison of mean tear film breakup time score. In the follow-up period after treatment with drugs at 4 weeks, there was no significant difference in mean tear film breakup time score between ribamapide and CMC groups. In both the groups, tear film breakup time score was found to increase gradually from 4 weeks to 12 weeks. At 8 weeks and 12 weeks, tear film breakup time score was significantly more in ribamapide group than CMC group, p-value less than 0.05. Comparison of mean ocular surface disease index score. In the follow-up period after treatment with drugs at 4 weeks, there was no significant difference in mean OSD score between ribamapide and CMC groups. In both the groups, the OSD score was found to decrease gradually from 4 weeks to 12 weeks. At 8 weeks and 12 weeks, OSD score was significantly less in ribamapide group than CMC group, p-value less than 0.05. Discussion and results. In 2007, the International Dry Eye Workshop updated the original definition and classified dry eye as a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance and tear film inability with potential damage of the ocular surface. Carboxymethyl cellulose has anionic characteristics which causes lengthened tear retention time that could influence the tear film stability, leading to reduction of tear film hyperosmolarity and possible inflammation alleviation. Ability of ribamapide to increase gastric mucin led to investigations of its effects on ocular surface mucin and the subsequent development for use in dry eye patients. A latest study shows that ribamapide augment mucin-like glycoprotein and MUC1 and MUC4 gene expression when human corneal epithelial cells were nurtured with ribamapide. In our study, the patients on ribamapide eye drop improved significantly in relation to the signs and symptoms of dry eye. Shizuka Ko in the study on treatment with ribamapide found significant increase in the TFM breakup time at 2 and 4 weeks after initiating the treatment compared with the baseline, and significant changes were seen in Schrammer's test score 4 weeks after the treatment, although there was no significant difference at 2 weeks. Similarly, S. Kinoshita observed significant difference at 4 weeks between ribamapide 2% and placebo groups. In our study, a significant difference of mean Schrammer's and TFM breakup time score between 2% ribamapide and 0.5% CMC groups was observed at 8 and 12 weeks. It suggests that ribamapide 2% eye drop improves the tear production and quality in dry eye patients by increasing the mucin production from droplet cells. The reported adverse effects were similar between the two groups. However, there are few constraints to the current study because the sample size was small and follow-up was short. Conclusion: in the treatment of dry eye disease, the 2% ribamapide was more effective and better tolerated. Response to ribamapide was more as compared to carboxymethyl cellulose in treatment of dry eye disease. Thus, ribamapide is superior to carboxymethyl cellulose in long-term treatment of dry eye disease, and such improvements should contribute to improved quality of life in patients with dry eye. References are as follows. Thank you.
Nice, that was a meticulously done study. So we have some anterior segment surgeons who have just joined us here. I'd like to welcome Dr. Abha Kanade madam. She has just joined. Dr. Rajesh Joshi sir, if they are around, would you like to comment on this particular paper on dry eyes?
Sir, so there is a lot of difference in the atmosphere during the January and this. So I want to know what is the difference between this. How can you compare this with the same? It is not the same atmosphere during this. Yeah, the season is different.
So that can be a confounding factor. That's what you're saying.
The atmospheric, it wasn't, whatever patients were coming, we have taken it for the study. The seasonal variations were not taken into consideration.
Okay. Probably you can keep that in mind in your future observations. That's a good point, Dr. Abha, madam. Thank you. Anyway, wonderful paper, Dr. Priyanka. And with that, we proceed to the next one.
So next we have a beautiful video by Dr. Praveen masking the unsightly lenticular opacity.
This 26-year-old male presented to us for the cosmetic improvement with a complicated mature cataract in a blind eye. Doing a cataract surgery in this eye would have caused a lot of intraocular complications. This patient was having a total retinal detachment, ectropy on UV, and the angle neovascularization. Even if you take a cataract in this patient, the chance of having a white reflex because of total retinal detachment is always there. So we posted this patient for the intracorneal tattooing. The surgery began with taking an initial incision of around 250 micron depth and using a blade to make a corneal pocket. Initially, we separated the corneal lamellae with the help of knife, followed by the corneal lamellar separator, which we use in a case of corneal lamellar surgeries. A blunt dissection in a slow manner is needed here, as the patient was not having a very adequate intraocular pressure. A circular corneal pocket made all over the unsightly lenticular opacity. The care is taken to cover the opacity all around and make it a circular one. The candle soot is collected with the help of 2 burning candles and the steel pot. This is a very easy method and you get ample of soot. The soot is then collected with the help of a tissue paper and is then used for the intrastromal The soot is then carefully placed inside the corneal pocket which we made already and is sprayed evenly all around with the help of iris depositor. Ample amount of soot is used so that it should not faint with the time. As you can see here, the soot sprayed evenly in the corneal pocket is very effective in hiding the unsightly lenticular opacity. Doing this extraocular surgery in a blind eye with lot of intraocular issues have avoided many intraocular complications like hyphema, risk of having a white reflex after surgery. The corneal pocket or the corneal flap is then closed with a 10-0 interrupted suture so that the soot remains in the corneal pocket and doesn't fade with the time. This is a very simple surgery and it helped tremendously to improve the appearance of a young patient after closing the corneal lip with the help of 10-0 suture. The excess of soot then is washed away with the help of balanced salt solution. And this is the post-op photograph of the same eye and the patient is very happy. Thank you for watching.
Beautiful work, Dr. Praveen. Just one quick comment. How would you like to basically compare this with corneal tattooing? Sir, you can unmute yourself.
Yeah. Can you hear me now?
Yes, I can.
Yeah. I couldn't understand your question. Please repeat.
Yeah. So how do you compare this technique with corneal tattooing?
Actually, this is one of the type of intrastromal corneal tattooing, and the another form would be doing a multiple stromal puncture and using the India ink sort of thing, right?
Right.
But due to multiple stromal puncture in the center would not have given me the circular shape, the first thing, and it might not be a very uniform pigmentation there, right? And the chance of fading with the time is more with the intrastromal the multiple stromal puncture technique than the intrastromal soot technique.
Wow, wow. Really appreciate your innovative and cost-effective way of helping the patient.
Yeah, in some eyes, when the intraocular pressure is not adequate, there may be some problem while doing the pocket, and so when that situation, you can try doing a multiple stromal puncture with the Indian technique.
Thank you for your inputs. So next, we are going to have Dr. Tagare, who will present his work on infectious keratitis.
Wonderful, wonderful presentation, Dr. Praveen. Thank you.
Thank you, Pritam.
And Rohit, how many now do we have left remaining?
We just have a couple of free papers. We are on time.
Okay, great, super.
Yeah, Dr. Shivraj, please go ahead. Can you give the voiceover, Dr. Shivraj Tagare?
Dr. Shivraj, you can speak yourself and tell us to move the slides. Rohit, if you're facing a problem, then you can show another one.
Sure, I'll do that. We have Dr. Anjali Singh.
Yeah, she's here. I can see her on the board.
Yeah. Descriptive analysis of allergic etiology of keratoconus. Just give me a second.
Yeah.
Hello.
Yeah. So, Dr. Anjali, can you give the voiceover? I will move on with the slides.
Dr. Shivraj, we'll come to your presentation after this, if you don't mind.
Sir. Yes.
Dr. Anjali, I am again starting the presentation. Please give the voiceover.
Yes, sir.
Please start, Dr. Anjali.
Wait, your screen is still not sharing, Rohit. It's still.
Okay, sorry. I'll just reach.
Yeah.
Is it seen now?
No. Yeah.
Yeah.
Go ahead. Dr. Anjali, you can start.
Yes, sir. Good afternoon, everyone. Myself, Dr. Anjali, and I'm going to talk about descriptive analysis of allergic etiology. So many times we see such pediatric group of patients who come with complaint of itching and redness, or even diminution of vision. And then we have their parents who are so confused and worried about the cause of the problem and whether it is treatable and what they can do. So we went through the literature and we saw, here I'm quoting two articles from Dr. Damien Gettinel, in which he mentioned that keratoconus is not a genetic disorder, but it is mainly a disorder due to vigorous rubbing of eye, which leads to release of inflammatory markers, and that ultimately disturbs corneal stroma and causes thinning and ultimately keratoconus. Next. So now it's a well-established fact that keratoconus is related with allergic conjunctivitis. So why we conducted this study? So our purpose was to find out which factor of allergic conjunctivitis is related more with the keratoconus. Next. So we wanted to study the correlation between severity of allergic conjunctivitis. So it was a cross-sectional sectional study, the inclusion criteria was signs and symptoms suggestive of allergic eye disease and age group of 4 to 30 years. And exclusion criteria was any other type of conjunctivitis with age less than 4 or more than 30. So how we conducted this study, we examined total 200 eyes. A detailed clinical history was taken. Best corrected visual acuity was done. Detailed clinical examination was done. Slit lamp microscopy, keratometry, video keratography, and Amsler chromic criteria was used to grade keratoconus. Next. Next. So here are the results. Here, talking about keratoconus, the maximum number of patients were from the age group of 11 to 15 years. Next, and maximum patients were male. So, okay, we calculated correlation of coefficient between various symptoms of allergy and keratoconus, and the highest was with astigmatism, followed by rubbing of eyes, followed by limbitis. Next. Here we know that there is an association between allergic conjunctivitis and keratoconus, and corneal topography can diagnose keratoconus. But by this study, we are trying to emphasize that on what symptoms and signs we must look thoroughly and subject patient to topography. So patients presenting typically with vigorous eye rubbing and limbitis should be subjected to topographical examination. Thank you.
Beautifully conducted study.
My study about infectious keratitis in pediatric age group, both infectious and non-infectious. So moving on to infectious keratitis, one of the leading causes of monocular blindness in the world. Non-infective causes of corneal blindness include vitamin A deficiency, chemical injuries, traditional medication. Incidentally, there are common causes of corneal blindness. Apart from infectious, non-infectious are also found to be pretty common, especially in developing countries due to nutritional deficiencies. So keratitis can lead to a scar formation, which is of highly clinical significance, especially in pediatric age group, because there is a huge propensity of developing sensory amblyopia in these children. So aim and objective of my study is to determine the etiological agent, predisposing factors, time lag of presentation, clinical features, microbiological profile, treatment protocol, time required for resolution of the ulcer, and outcome of treatment in terms of structure and visual acuity of infective and non-infective keratitis in children. Materials and methods. So this is a retrospective study of 345 patients conducted between January 2018 to December 2019. The records of patients of 16 years or less diagnosed with infectious and non-infectious keratitis were reviewed to assess the visual acuity, demographic data, predisposing factor, clinical course, microbiological culture results, treatment, structural outcomes, and visual outcomes following the treatment. Microbiological scrapings were obtained under topical anesthesia, or in cases of children who are non-cooperating or like less than 5 years of age, general anesthesia. Microbiological evaluation includes scraping for smear followed by subsequent sequential scraping for culture plating, either in blood agar or potato-dextrose agar. If the ulcers were suspected to be caused by an unusual organism such as nocardia or acanthamoeba, smear results were positive. When the smear results were positive for them, additional relevant culture media were used. Eyes were treated initially based on clinical evaluation and followed by micrological smear examination. The treatment was modified. The treatment was modified based on the culture also. So going down to results, it was found that maximum number of patients presented within 1 to 5 days of onset of the inciting agent. And it was found that
etiology, infective keratitis was 93.2% compared to non-infective keratitis, which was about 6.8%. Next. Going on to this associated risk factor, it was found that most of the patients had no associated risk factor followed by trauma. In cases of trauma, it was found that stick injury was found to be the most common, followed by dust fall. So surprisingly, other etiological agents like surgery, use of contact lenses, VKC, exposure keratopathy were also found to be pretty common. Among trauma, fingernail injury and among trauma, fingernail injury, chemical injury, and trauma by toy was also found to be pretty common. So moving on to clinical features, it was found that maximum number of patients presented with subepithelial keratitis, that is SCKs. Some of the patients also presented with stromal keratitis. Associated epithelial defect was found in epithelial defect was also found in many of the patients. Moving on to microbiological profile, on smear examination, it was found that fungal filaments were positive in maximum number of patients. And going on proceeding with the culture result, it was found that Nocardia, Pythium, and Pseudosporidium are most common in southern part of the country. Culture results were positive in about 60% of smear positive results. So in my study, it was found that maximum number of patients of etiology were of viral keratitis, which was followed by bacterial and fungal keratitis. It is also found that Madar juice tox and adenoviral keratoconjunctivitis was also found to be common in these patients. Maximum of patients healed with medical treatment, followed by TPK and glue with BCL. Patch graft was rarely used in my study. Amniotic membrane grafting was also used in the study. Anatomical outcome, it was found that about 47.8% of patients healed with corneal scar, which is of huge significance as it led to sensory amblyopia, as the scar was in about the critical period. So it is very necessary in order to diagnose the patients as early as possible, as diagnosing early and treating early will always lead to a favorable anatomical outcome and decrease the probability of having scar, and hence the profitable or better visual outcome as well as anatomical outcome for the children. So it was found a maximum number of patients healed with medical treatment, and other surgical modalities were rarely involved in this study. This study also showed a final visual acuity of better than 6/12 or 80.3% in patients presenting early, that is within 5 days, while 60% were in late. So as early the patient presents, the more favorable is the outcome. Conclusion of my study is infectious keratitis is more common than non-infectious pediatric population. Early diagnosis treatment leads to better outcome. Medical treatment can be initiated depending on clinical features and modified according to the culture and smear results. Patients should be closely followed as some ulcer can lead to corneal melt and perforation. Thank you.
Beautifully done study, Dr. Shivraj, and the sample size is quite huge. I should really appreciate that.
Thank you, sir.
The results.
Yes. Thank you.
I would request our resident officer, Dr. Sunila ma'am, to comment on the paper.
What do you want me to do? Hello.
Good afternoon, ma'am.
Good afternoon. Yes.
Dr. Shivraj presented his paper on the pediatric infectious keratitis, the experience of more than 300 patients in a tertiary care center in South.
I remember his paper from the 1st November session also. Very good paper. And the number of patients is huge. Actually.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am. Thank you so much, ma'am.
Thank you.
Uday, are you ready?
Uday, unmute yourself.
Actually,
I'm not very well versed with this thing. I'm searching for my presentation to share.
It's okay.
Presentation share करायचं मला. Screen share करायची.
Uday, share your screen. Share your screen.
Yeah. One sec, ma'am. Share. Screen share करा.
No, but first of all, keep your presentation on your desktop, on the screen of your laptop.
I had done that, but I thought
now share screen. Click on share screen. It'll open. It should open. Go on the green button and do share screen. No, you are not. You haven't done it. Click on the green button at the bottom.
At the bottom, there is no green button.
Are you logging in from your mobile? Or from there has to be a green button. If you are
No,
in Zoom.
I am logging from my laptop, from the link which has been given by the mail.
That's okay. So the link is correct.
You are there in the meeting. The link is correct. There is a button at the bottom. Just see a green.
Uday doesn't know how to link in.
Host has disabled participant screen sharing. That's what coming.
Okay, Pritam.
Should we go into the next talk or should I help Uday?
Person, go ahead. We'll manage that, Uday. Don't worry. I think Hema, he's been disabled to share screen. Why should that happen? I'll manage. I'll talk to the organizers. I'll talk to the event people. I think someone from them should be there. In the meantime, we can go on to the next talk.
Dr. Snehal Thackeray, are you there?
I'm there. Yeah.
You can start with your talk. I invite Dr. Snehal Thackeray to talk on refraction in a child.
Okay, thank you. Oh, it's same thing. Host disabled, participant screen sharing.
One sec.
Pritam, there's a problem. The host has been disabled, participant screen sharing.
Who's the
1 minute? Pritam's coming on. Huh?
Who's the Bodankar person here in this hall?
Hello.
Who Akhilesh? Are you the person? No. Oh, Pritam is coming. Pritam, they've disabled the screen sharing.
Dr. Snehal is not able to share the screen.
None of them. Uday also is not able to.
I just
call up. But one of their guys should be there, no? We had promised.
Hello.
Yes, who's there? Akhilesh?
Yes, ma'am. Ma'am, actually.
Akhilesh, can you enable the screen sharing for Dr. Snehal Thackeray, please?
For all. For even. You just open up the screen sharing. Akhilesh.
I called up the person. He said he's doing something.
Yeah. So can you try again, Dr. Snehal?
Yeah, I'll do that. Share. Okay.
No.
Yeah. Okay.
Yeah, it's
yeah, we can see your screen. Go ahead.
Yes, go ahead.
So
everybody else is mute.
Okay. Good afternoon, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. Today, my topic is refraction in a child, which can be quite challenging as children do not cooperate, their attention span is less, and strong accommodation accommodation plays a role. Accuracy is very important because many a times we have to give objective correction. So today I aim to solve the few questions like who should undergo refraction, when should the refraction be done, how should it be done, which is the right cycloplegic agent to be used, how much is a refractive error, how do we calculate that, and then how do we decide does this child need these glasses. But the first important question is why should a child undergo refraction? Uncorrected refractive errors lead to amblyopia, which is a needless preventable cause of visual impairment. And refractive errors, uncorrected and corrected, are intricately related to the diagnosis and management of strabismus. In Feb 2020, the Pediatric Ophthalmology Expert Group has released the consensus criteria regarding the pediatric eye examination, refraction, and amblyopia management and made life simple for us. So most of the things which I'm going to tell are from these criteria. All those children who fail a preschool vision screening, which should ideally be done at the age of 3 to 4 years, but unfortunately there are no guidelines, Government of India guidelines for this, should be refracted. Earlier vision screening and refraction should be done in children with history of prematurity, nystagmus, strabismus, developmental delay, and high refractive errors in the family. And of course, those who are symptomatic. Now, symptoms can be variable, vary from headaches, eye strains, holding things close, but we should also pay attention to the asymptomatic children who may just have a poor school performance or poor attention. So the pediatricians should be made aware that these children should undergo a refraction. So the only way to do a refraction in a child is to do a cycloplegic refraction. Two dilemmas arise next. Which is the right cycloplegic agent, and should the child undergo a retinoscopy or an autorefraction? Again, the national consensus criteria come to a great help here, which state that in children with esotropia less than 5 years of age, atropine 1% eye ointment 3 times a day for 3 days is the only way. Whereas in children more than 5 years of age with or without any strabismus, especially esotropia, you can use either atropine 1% eye ointment, cyclopentolate eye drops, or home atropine eye drops. But atropine can be quite cumbersome in children because it can, especially in the school-going age group. So a common regimen which can be used in older children is cyclopentolate 1% or home atropine 2%, 1 drop 15 minutes apart, followed by a drop of commercially available combination of tropicamide and phenylephrine. Retinoscopy should be performed at 45 to 60 minutes after instillation of the first drop. And you should ensure that proper cycloplegia has been achieved by seeing that there is a constant value at near and distance. Before instilling cyclopentolate eye drops, we should always rule out a history of any prior convulsions or any significant neurological problem. The next question is whether to do a retinoscopy or autorefraction. Again, here the consensus criteria state that cycloplegic retinoscopy is the gold standard. Accuracy of cycloplegic autorefraction is questionable in infants and toddlers, though it can be used in school-going children. As late as September 2020, a report by the American Academy of Ophthalmology also concluded that cycloplegic autorefraction is appropriate to use in pediatric population, but with a caveat that cycloplegic retinoscopy is valuable to confirm the accuracy of this refraction, especially when corrected visual acuity is worse than expected or autorefraction results are not consistent with expected findings. The lesson here is that we cannot afford to forget how to do our retinoscopy. So we know that we do not prescribe the exact retinoscopy readings. We subtract for the working distance and the cycloplegic agent. As you can see from the table here, that as the working distance reduces, the amount subtracted increases, and as the cycloplegic becomes weaker, the amount subtracted also becomes lesser. The previous tables have helped us decide what is the refractive error present in the examined child. But then again, we have to decide whether the child needs the glasses. Factors considered here are age of the child, type of refractive error, amount of refractive error, presence of anisometropia, and presence of strabismus. Again, the national consensus statement comes to our rescue, and if we follow this table diligently, there should be no confusion about who requires the glasses. Now I will mention a few special conditions like esotropia. In infantile esotropia, a trial of glasses is given even if the retinoscopy reading is plus 1.5 diopters. If there's a refractive accommodative esotropia with normal AC by A ratio, you have to give full hypermetropic correction. With high AC by A ratio, executive bifocals with or without distant correction as needed are given. Taking note that the executive bifocal's lower segment should bisect the pupil. In partially accommodative esotropia, the parents and the patient should be counseled that glasses will be needed after surgery also. In intermittent exotropia with myopia, myopia correction can be given as per the recommended guidelines. An overcorrection of up to minus 0.5 diopters can be tried in children more than 3 years of age. As the child grows older, they may not tolerate this overcorrection, and then you have to take a call whether surgery is required or not. In intermittent exotropia with hypermetropia, classically what happens, correcting hypermetropia can worsen their exodeviation. This has to be explained to the patient. At the same time, we have to prescribe minimum correction if vision is compromised without glasses. In some patients, correcting hypermetropia may improve the fusional convergence and lessen the exodeviation. In aphakic and pseudophakic children, Retinoscopy will give an idea of what the refractive error is. We have to remember that children less than 2 years are more interested in their near field of vision. So we have to give them a plain near correction. So children less than 1 year of age, you give a +3 add over the distant correction, whereas in children between 1 to 2 years of age, you give a +2 add. In children more than 2 years of age, when they're more interested in the distant viewing also, we give bifocals. A few special situations I would like to mention that early prescription of glasses by 6 months of age should be considered in children with ROP who may have a progressive myopia, in children with gross developmental delay, and also in Down syndrome. Protective glasses are to be considered in one-eye children, and tinted glasses in children with albinism, and so on. One of the newer considerations is myopia management. With the increasing incidence and prevalence of myopia, we should not only, if we cannot prevent the onset, we should at least try to control the progress of myopia. This includes some advice regarding reduced screen time and time spent on indoor activities, as well as increasing the outdoor activities. Up till now, we have been giving optical correction only for the in the form of single vision lenses to improve the vision. But nowadays, there are options available in the optical correction in the form of executive bifocal lenses, peripheral defocus lenses, progressive lenses, orthokeratology, to reduce the progression of myopia. And pharmacological intervention in the form of atropine, 0.01% eye drops, HS for at least minimum 2 years has been shown to reduce the progression of myopia by 50%. Before I conclude, a few tips. Again, I would like to emphasize that rule out the history of convulsions, neurological problems before instilling cyclopentolate. Instill a drop of proparacaine before the cycloplegic agent, less stinging and more cooperation from the child. Maintain a constant vertex distance, the distance at which you hold your loose lens from the eye, and a constant working distance, the distance at which you are from the eye. Then do an on-axis retinoscopy. If the patient is having a strabismus, close one eye and make the squinting eye straight, and then do the retinoscopy. Make sure the glasses fit properly over the ears. The frame is of an optimal size, and the optical center of the lens is opposite the pupil. As for the material of the lenses, they can use high index plastic, CR39, Trivex, or polycarbonate. To conclude, cycloplegic refraction is a must. If the child is not using glasses, find out why. Check if they are comfortable, centered, of the correct power. Repeat the cycloplegic retinoscopy. Maybe you can use a stronger cycloplegic. Rule out any other cause of diminished vision. Myopia control needs special attention. Consider the various options and choose the appropriate one. Thank you. Thank you.
Thank you, Snehal. That was a very nice overview of refraction in children. And I think you gave us some very good tips. A small tip from my side, because I am not into using cyclopentolate at all for hyperopic patients, hypermetropic patients or myopic patients, because you don't know what the refraction is going to turn out to be in a child who comes to you for the first time. So I always give them hometropine. But the problem with hometropine in children is, I've discovered, it takes a very long time to dilate. So a small tip is, give them hometropine to be put at home every 15 minutes for maybe 2 hours before they come to you. And when they come to you, add a drop of T+, and it works. Then the pupil dilates actually. Otherwise it doesn't. And the homide has already done its work. So the accommodation is already paralyzed. But the pupillary dilatation comes with adding of T+. Okay. Can we now, Hema, would you like to call Uday?
Yeah, Uday, are you ready?
Yeah, I'll be sharing my screen. Yeah, it is saying that this will stop others' screen sharing. So I'm clicking yes.
Yes. Go ahead. Yes, you started. Yes.
First of all, I would like to thank coordinators for allowing me to be an odd man in rather than an odd man out, because all the presenters are female and I am the only male guy over here.
You're lucky Uday.
I don't know who is lucky, you or me. Okay, anyway, I will be trying to, one sec, I'll set my watch so that I should not overshoot. I'm attempting to talk on motor evaluation of the strabismus. This is really a tough job like this. Why motor evaluation we do is it gives us the exact status of ocular motility and status of extraocular muscles. It helps in diagnosis as well as planning the surgical treatment. So we'll start with the Heisenberg test. What we do is we shine a pen torch in the patient's eye and look for the corneal light reflexes. If those are displaced temporally, we call it as esotropia. If displaced nasally, we call it as exotropia. If displaced inferiorly, it's a hypertropia. If displaced superiorly, it's a hypotropia. 1 millimeter of displacement of the corneal reflex roughly equals 7 degrees of squint. So these are examples of 15, 30 and 45 degrees of squints. After that, the conjugate binocular movements, that is versions, followed by uniocular eye movements, that is ductions, are to be tested in all the 9 diagnostic gaze positions. These 6 cardinal gaze positions, we test one muscle from each eye, which is predominantly responsible for that movement. Superior rectus, lateral rectus, and inferior rectus, they are tested in abduction. So diagnostic positions for these 3 muscles is extraocular muscles is of abduction, and for superior oblique, medial rectus, and inferior oblique, they are tested in adduction. Each muscle under action or over action is noted, and it is recorded or graded in the scale of -4 to +4, and it is recorded in the form of 2H. So we'll see what is normal and what is abnormal. If the junction of medial 1/3 and middle third of the limbus touches the punctum, then the adduction is normal. But if it is more than that, there is overaction of medial rectus muscle, and if it is not touching that, there is underaction of medial rectus or adduction is deficient. The lateral limbus should touch the lateral canthus. Then only abduction is said to be normal or lateral rectus is acting normally. If not like that, then it's a underaction. The next most common muscle to overact is inferior oblique, and it is tested in dextro elevation for the left eye and levo elevation for the right eye. The elevation in the adducting eye is noted. If it is more than that of the other eye, then inferior obliques is said to be overacting. Inferior oblique overaction leads to V pattern. That is, as can be seen in this, that exotropia is increasing as the upgaze is increasing. So one thing to be always remembered is exo more in up is V, and from this single you can derive all the other patterns which can be there. So inferior oblique overaction can be graded as 1+, 2+, 3+, and 4+, depending on the angle which the tangential lines passing through the pupillary centers of both eyes make. Now in this case, the elevation in the abduction appears to be okay. In elevation also it is okay, but in adduction there is complete absence of elevation, and this typically happens in Brown syndrome. Superior oblique action is tested in the adducting eye in the depression, like in the dextro depression and in levo depression. If the adducting eye is depressed more as compared to the other eye, it is superior oblique overaction, and superior oblique overaction leads to a pattern, as can be seen that exotropia is progressively increasing in the down gaze. Now the right and there is inferior oblique overaction of the right eye, and you can see the adducting eye is less depressing. This is superior oblique underaction, which typically occurs in superior oblique palsies or paresis. This patient presented with vertical diplopia trauma, and you can see affected movement is depression, which is maximally affected in abduction. So that is the area where inferior rectus act. On imaging, she was found to have inferior rectus entrapment. This patient having left hypotropia, again the elevation was most affected in the abduction. On imaging, this patient was not having superior rectus at its place only. This consecutive exotropia patient presented who was operated for esotropia in the childhood. If we see, the adduction in the right eye is completely normal, but the left eye is not adducting completely. Actually, it was a case of slip medial rectus muscle, and I had to explore and re-advance the medial rectus to its original place. That took care of her exotropia. This is routine third nerve palsy with total ptosis and limited elevation, depression, and adduction of the right eye. This is an interesting patient, young patient who presented with diplopia and had signs suggestive of partial third nerve palsy. On imaging, she had thickening of the optic nerve was quite consistent with hemiplegic migraine, which she responded well with treatment. The change in the interpalpebral fissure height has to be also noted so that it gives us clue towards the diagnosis, like narrowing on adduction and widening on abduction points towards DRS. In this child, look how her eye downshoots and upshoots. This is again typical of DRS. If patient is presenting with ptosis, pseudotosis has to be ruled out, because sometimes doing only squint surgery might be satisfactory for the patient, because only squint surgery can make the eye fixing, and his or her ptosis can reduce. The next important part is cover test, and the most prerequisite is the fixation should be adequate. Means vision should be good of the patient, as well the patient should be intelligent so that he can follow your instructions. Cover tests are done for near as well as distance and with and without corrections. Most important is the targets are to be given, which should be accommodating targets, and anything you can use like palm of hand or Spillman occluder as a occluder. So cover tests, as we know, are done to reveal or manifest squint. So as in this case, the left was fixating eye. As soon as we cover it, the movement of other eye has to be noted. If it is coming from out to in, it's a exo. If it is going from in to out, it is eso. If it is coming from up to down, it is hyper. And if it is coming from down to up, it is hypo. Uncover tests are done to diagnose latent squint or phobias. I can covered, and what we have to note is movement of the just uncovered eye, as in this case there is exophoria. Now uncover tests are known done to know whether the squint is present bilaterally or unilaterally. Those are done for near as well as distance. So it is, we cover the first fixating eye, note the movement of the other eye, then shift the cover to the other eye and note the first eye, and this is repeated multiple times. And what we need to look for is, when we remove the cover and place it in, we remove the cover, the previously open eye, whether it maintains the fixation or not. If both the eyes are able to do such way, then bilateral squint is there. After cover test comes measurement of deviation, which can be done with loose prisms or prism bars. Apex of the prisms has to be kept in the direction of the squint, but we talk in the language of base. So for esotropia, the prisms are to be kept base out, and for exotropia, the prisms are to be kept base in. The amount of prism strength which is required to offset all movements of redress gives us the measurement of the squint. Points to remember here are, measurement should be done for near, distant, and all diagnostic positions. We have to neutralize horizontal first and then vertical. Squint measurement has to be done with and without refractive treatment, and patient should never be allowed to fuse in between the tests. To rule out pseudo-divergence excess exotropia from true divergence exotropia, we do patch test after minimum of 45 minutes of patching. After patching, near deviation should increase and come within 15 prism diopters of that of distance deviation. Then only pseudo-divergence excess is present. But if such an discrepancy remains, then we have to do +3 diopter test and rule out high AC by A ratio. The eyes, squinting eyes in which there is no useful vision, to measure the squint, have to do test. patients, we have to do 3-step test, but the fallacy with this is that it is suitable and accurate only in recent onset palsies. So these are the 3 questions we need to address. In long-time standing squints, in restrictive squints, status post-trauma, and in paralytic squints, sometimes we have to do post-duction test, which can be done after appropriate anesthesia in OP in adults, but for kids, it has to be done in OR only. Regarding Hess charting, it's more of a prognostic value than diagnostic value. It can be serially done in patients with restrictive strabismus or paralytic patients to know what difference it has been done. So to summarize, proper motor evaluation, proper surgical planning as well execution leads to happy patients as well as happy surgeon. Thank you very much.
Thank you, Dr. Uday, for this fantastic presentation you made. Cover test looks so easy. Most of the times it's the postgraduates who who are very scared when they see a squint case, but you've explained it really nicely, the basic examination. Nipa, you have any questions? Dr. Nipa?
Yes, may I?
Yeah, sure. In the meanwhile, may I ask the next presenter to be ready with her presentation while Nipa takes the question? Dr. Zai?
Nice presentation. It covered everything. I have a few questions. For your grading of extraocular movements, whether it is an under or an overcorrection, do you use the 0 to 4 grading or do you use something else? And when you're making a note for your grading, is there a cutoff for which you would treat, like you would take a -half or a -1 into consideration or just a -2? Is there any cutoff? Uday?
Actually, I think this is a case-to-case decision.
Uday, turn your video on. It doesn't matter. Go ahead.
I think this is a case-to-case decision. Like for -half or -1, when we have to do it, like especially in cases of this question comes mostly when there is palsy, especially 6th nerve palsy patients. Yeah, definitely. If in 6th nerve palsy, if it's a paralytic condition, then -half or even -1 would be taken care by recess resect. But if it's more than that, we have to do some other procedures like transposition procedures and all. And regarding the overacting muscles, it is most commonly in obliques, especially in inferior obliques, that 1+, 2+, 3+, 4+ overgrading is most commonly done. And I usually do weakening in inferior obliques if they are 2+ or more.
Okay, I was just, yes, that's very nice. I'm just looking for consistency in recording. So do all of us record 0 to 4 as a scale for under and overaction, so that when we see patients after some time, or if we see each other's patients, we are all consistent in is that some recording system that we all follow? Do you follow the 0 to 4?
Actually, this should be universal. Actually, most of the times recording of all these underaction and overactions are done subjectively. Even when we started doing this, we categorically started noting 1+ as 1+, 2+ as 2+. But what I have personally noted that over the time, our 2+ maybe 3+ sometimes, just like in cataracts, the NS2 is NS3 or NS4 for somebody. But it is the NS2 for somebody else. So I still think that this is subjective gradation, which is practice, but for uniformity, it should be universal gradation. And I think more and more pediatric ophthalmologists, they come out, maybe it would be in the near future that we all will be following universal grading.
Thank you.
Sai, are you ready with your presentation, Dr. Sai?
Yes, I'm ready.
Okay, we'll go ahead.
Yeah, sure. So, can you all see my screen? Shall I start?
Yes. Yeah.
So, it's nice to be in MOSVIRCON, though virtually. I must thank Himalini Samant and MOSVIRCON for giving me this chance. So, Today I'll be talking on intermittent exotropia, surgical treatment strategies. So exotropia always presents us with a conundrum because it's intermittent. Half the time the patient is squinting, half the time they are not. So what are the goals of surgery? We want to align the eye at all times. It shouldn't be intermittent anymore, and try and preserve or restore the binocular function. So popular intervention criteria are a reduction or loss in stereo acuity at near or distance, a deteriorating fusion control, large angle of deviation or a combination of all the three, and an increase in tropia phase. So the timing for intervention is very important. However, the optimal time for surgical intervention still remains unclear. The critical point is the post-operative stereo acuity establishment. So you have to decide what age the patient is presenting to you. Will your surgery give them a stereo acuity? If the child is less than 2 years of age, maybe that can be attempted. But anything beyond that, what we are doing, stereo acuity may not be there, but the eyes will be aligned. In children, early surgery is indicated to prevent progression to constant exotropia, and then you can have some hope of restoration of the bifoveal fixation. In most adult patients, surgery can only help to achieve orthotropia, but not the bifoveal fixation. The Newcastle Control Score is a useful measure of clinical severity, and there are some enthusiastic parents, and if you can involve them in assessing how many times the child is squinting in a day and coupled with whatever you are seeing in your clinic, definitely helps in assessing the improvement or deterioration, and is a useful tool for management of patients of intermittent exotropia. So there is a role of orthoptic exercises also. So in order to avoid diplopia and other symptoms, patients with intermittent exotropia may develop anomalous retinal correspondence and suppression. So post-operatively, positive correcting exercises such as synoptophore exercises should be administered to restore normal retinal correspondence and enhance the binocular function. Patching after surgery is what I advocate irrespective of age, because that is how the patients are used to. Their brain has to get used to seeing with both eyes is what we can tell them. And in case the synoptophore exercises are not possible, patching also can take their place. So let's look at the type of intermittent exotropia and how would you manage them. So this is a old class, the standard classification: basic exodeviations, divergence excess, which is true and simulated, and the convergence insufficiency. So it is important to classify because your treatment options, the surgical options, will differ depending upon how you have classified the exotropia. So let's look at the basic type of exotropia, where the deviation for distance as well as near is exactly the same. So what has been advocated for this is unilateral recess resect surgery. And why is that? Because surgery on one eye was found to be more effective. It gave 82% success than surgery on both eyes. For divergence excess exotropia, where the distance deviation exceeds the near deviation, symmetric lateral rectus recessions are recommended. And why is that? Because it works on the assumption that bilateral lateral rectus recessions would affect the distance deviation more than the near deviation, and a recessed resect procedure would affect the distance and near deviation equally. So we don't want that to happen here because it's a divergence excess. So bilateral lateral rectus recessions for a divergence excess exotropia. If it's a simulated divergence excess, then many patients with an apparent divergence excess of exotropia would manifest with an increase in their near deviation with 1 hour of monocular occlusion. So surgery then should be performed for the largest angle which is measured. Otherwise, the patient is going to have a residual exotropia, and that is going to be manifest after your surgery. Kushner also further subdivided Burian's classification of the divergence excess by an excess of divergence or excessive accommodative convergence. So they believed that these patients really had a near deviation that equaled the distance deviation, but it was masked by fusional divergences at near. So they recommended that they be treated as the basic type of exotropia. That means in these patients, it is recommended that you do a recess resect procedure. Again, the problem arises whether you want to do a bilateral surgery or a unilateral surgery. So long term, that's a 2-year survival analysis of bilateral lateral rectus recession versus unilateral recess resect for intermittent exotropia concluded that though the surgical outcomes were comparable in both the groups, the final outcomes were better in the bilateral recession group than in the recess resect group. So this can be caused by differences of the occurrence rate over time. So continuous recurrence of exotropia in the recess resect group when the recurrence was low after 6 months of bilateral lateral rectus recession. So what would be the surgical dosage and what about the age of the patient? So younger the patients are less than 7 years in whom surgical dose was reduced, there was no significant change in the success rate. It was 77% compared to those who had surgery using the standard tables, that is 75%. Abrams et al. Have proposed that patients may achieve a superior sensory outcome with motor realignment before age 7 or less than 5 years of strabismus duration. And Young et al. Are of the view that surgery needs to be postponed for several years because intermittent exotropia can still fuse and hence bifixation can be obtained even if operated late. And not all intermittent exotropias are progressive. Also, the deviation may remain stable for many years, while in some cases it can even improve because you're providing them with orthoptic exercises. They definitely have a role in helping these cases. Some researchers also thought that patients might easily achieve the binocular function if operated after 7 years of age and over 5 years of strabismus duration. Favorable results after surgical intervention before 2 years of age have also been reported by some authors. The increase in tropia phase, this is what happens in many cases of intermittent when they start decompensating from an intermittent phase to going towards constancy. So that's an important indication for therapeutic intervention. That is, the tropia phase is increasing. We also obviously means that the fusional control is deteriorating. So the progression should be monitored by documenting the size of deviation, the duration of manifest deviation, and the ease of regaining fusion after dissociation from the cover-uncover test. If the patient is taking long to recover from the not recovering the fusion after the cover-uncover, obviously that it points towards the increase in tropia phase. The increasing frequency or duration of the tropia phase indicates diminished fusional control and potential binocular function loss. Sharma et al. Have also proposed that distance stereo acuity as an objective measurement and indicates that that is the time that you want to intervene surgically. The true surgical outcome, however, is difficult to determine because there is a lack of standard definition for a successful outcome. There can be a variability in classification systems. There are multiple treatment approaches, and no matter how many years we have been treating intermittent exotropia, still there is a paucity of long-term data. So the success rate will depend on the length of the post-operative follow-up. Longer the follow-up, higher is the chance of incidence of recurrence. In recent studies, the reported success rate in all types of intermittent exotropia has been about 60 to 70% cases. So intermittent exotropia has a tendency that it can come back. It can come back and haunt you, even though patient has been following up well. At least the importance of follow-up is you can pick up the recurrence very fast and again start orthoptic exercises, and that can definitely help them start fusing again. Undercorrection, overcorrection again are very common here. Use of basin prisms for power greater than the residual deviation has been associated to provoke the convergence and lessen the exodeviation. Similarly, for overcorrection, the rate can vary between 6 to 20%. The second operation should not be performed until at least 6 months have elapsed, except when there are significant limitations of ductions and it can cause an incompetence in lateral gaze. In older patients, that's patients older than 12 years in whom surgical dose was increased, there is a statistically significant increase in success rate. So you can err towards operating on the higher side rather than on the lower side. You don't want, because undercorrections are more common in intermittent exotropia. So you remember that you have to modify the surgical dose according to the age, which can improve the success of patients in intermittent exotropia. So to conclude, the preoperative deviation is one of the strongest predictors for favorable surgical outcome. Surgery with preoperative, orthoptic and occlusion therapy has the highest success rate. So it was more effective in reducing the exodeviation compared with surgery alone. So always give a trial of orthoptic exercises before taking up the patient for surgery. Strabismus surgery can help to preserve or restore the binocular vision in intermittent exotropes. Children receiving the surgery at young ages develop better post-operative binocular vision, and post-operative synaptophore exercises, amblyopia therapy can definitely help restore the binocular vision. So studies in short term have been definitely shown the success rate of approximately 80%. Studies with 2 to 5 year follow-up show 50 to 60% success rate with one surgery. And in most of these reports, success was defined as an alignment within 10 prism diopters of orthophoria, and a mean follow-up was at least more than 4.5 years. So early detection of abnormal stereo acuity for distance and near fusion and convergence amplitudes may help to decide the proper timing in intermittent exotropia. Thank you.
Dr. Nipa, you have any questions? It was a lovely presentation, Dr. Zai.
Yes, very nicely done, Zai. I have two questions. Do you do a patch test for all your patients pre-operatively?
Preoperatively, yes. Intermittent exotropia, especially coming for the first time, definitely I put them on a patch for 45 minutes. Important thing to note here is that when you take them up for checking again, make sure that binocularity is not restored before you remove the patch. The patient should not get a chance to look with both the eyes. So remove the patch, occlude the other eye, and then remove the patch and do the cover test again. Definitely it helps, and I would recommend that should be done for every patient who comes with intermittent exotropia.
Nipa, you're muted. Nipa, unmute yourself.
The point I'm trying to drive home for all our friends is the patch test is a very important part of the pre-operative evaluation. And second question, Zai, is a post-operative esotropia is something that is recommended for the long-term success of intermittent exotropia correction. Is that something that you do in most of your patients? Esotropia post-operative?
Okay, if the patient is less than 5 years of age, maybe I will attempt a slight residual esotropia of about 10 prism diopters, not more than that. Because as the child will grow, with the growth of orbits and the eyes will start deviating outwards, I would expect an orthophoria to be gained by around 8 to 10 years of age. But if the patient is already 12 or 15 years of age, then I will not attempt an esotropia, not an overcorrection, but try to give an ortho position for that patient. But slightly would err on the side of esotropia and not keep them undercorrected.
Ma'am, you want to say something?
Yes. Actually, I have a personal interest in intermittent exotropia because my own grandson, who's 9 now, has it, and he's in the US. So I can't even check him up because right now, because of the corona situation more so. But he has been shown to a specialist there, and all they've recommended, he doesn't have any classes, though his father does. That means my son does. But all that has been recommended is wait and watch and pencil push-up exercises, which he's not doing. How would you go about this now, Jai?
Yeah, that's a very interesting question. Well, ma'am, I would really, I would like to know how much his deviation is, how many times in a day is he deviating, and if the angle, because more than the angle, it's the amount of time that he is deviating. If he's decompensating too many times in a day, then maybe he's going towards the requirement of surgery. If he's not deviating,
I don't think he is.
then there's still time, and pencil push-ups exercises will work like wonder for him. So counseling of parents is more important here.
Yeah.
He's just a 9-year-old. He's not going to, I'm sure he's terribly bored of this. But if you motivate the parents, which I'm sure it's very easy, but I think because he's your son, he's not.
Oh, my daughters-in-law are also very nice. Thank you.
Mita, you wanted to say something? Unmute yourself. Unmute yourself. Unmute yourself.
Sumita, unmute yourself.
Yeah, I've unmuted. It looks like unmute only.
Yes, you're unmuted.
You wanted to say something?
No, I just wanted to say that.
Should we start?
My personal experience with IDS has been, I've always been very conservative when it comes to an IDS patient. I kind of observe them, give them a lot of patching, correct the refractive error. And in my own personal experience, the longer you wait, the later you operate, the better are the results.
Yes. No, I just wanted to say I don't blame him. Pencil push-ups are very, very boring. No.
We can start with your talk, Sumita.
Yeah. Thank you for giving me this opportunity. Special thanks to Dr. Malik and Dr. Samanth here. And I'm very glad to be part of this symposium, even though I think it is still...
Our pleasure, Sumita.
Thank you. Thank you so much for thinking of me every time. So I'm going to talk about management of strabismus in thyroid eye disease. Well, thyroid eye disease is really a complex, potentially vision-threatening issue here, and the whole eye disease, it is, I think, now no longer called as thyroid orbitopathy or anything. It is probably thyroid eye disease because it involves several organs, several parts of the eye which are also potentially vision-threatening. So in short, there are probably two phases in the whole disease process. There is an acute inflammatory phase and a chronic phase. In the inflammatory phase, you have a lymphocytic infiltration and congestion of the orbital tissues. And in the chronic phase, this inflammation leads to fibrosis and restriction. From the strabismus point of view, we are interested only probably in the restrictive and fibrosis part of this spectrum here. So if you look at the strabismus in thyroid eye disease, it probably consists of 17 to 50% reported in the literature with patients with thyroid eye disease. However, it's my anecdotal feeling that in Indians, we don't see that much of thyroid related strabismus in adults compared to the Western, what has been reported in the Western population. Risk factors, again, which have been very easily identified are probably the middle-aged, again, women, because women tend to have thyroid eye disease more often. So strabismus is also more common. Smokers with TED are definitely twice as likely to need strabismus surgery compared to non-smokers who have thyroid eye disease. And of course, family history and genetics also probably plays a role here. So this is a typical patient with thyroid eye disease whom I present to you. As you can see, this patient has a clearly large esotropia as well as a hypotropia in the right eye and a very, very prominent proptosis. So when they come to, I think my slide is, some font has changed here, but basically when they present, they can either present with diplopia and during inflammatory phase, or they can present with really restriction of motility along with diplopia, or sometimes, very rarely, they often present with no obvious evidence of thyroid eye disease, but only with strabismus, and this can sometimes be confusing with a cranial nerve palsy, because they don't have dramatic limitations. They may not have proptosis, but just diplopia and strabismus. So this is a typical ocular motility limitation pattern, which a lot of us who have seen thyroid eye disease would have seen. Esotropia as well as hypotropia, which are the most common forms. And this is because the muscles which are involved often show a predilection, which is a pattern which is very, very commonly described. Like inferior rectus probably is the most common, followed by medial rectus, and then in that order, as mentioned here. And obliques, though not unheard of, but they are very, very rarely involved. Again, inferior rectus, why? Probably because it's a very, very bulky muscle and it is tonically very active because of the position it is in. And that's why probably it gets involved more often than any other muscle. You can have multiple muscle involvements, you can have bilateral, you can have asymmetric, asynchronous involvement. And of course, since the hallmark of myopathy is restriction, you will have a positive post-duction test in these patients. Investigations also look at your endocrinal status, because thyroid, though thyroid dysfunction has no direct relationship with thyroid eye disease, or rather strabismus in thyroid eye disease. You can have a really bad strabismus even in euthyroid state, but it is important for the patient's general well-being that you investigate for his thyroid level. For any diplopia, you would do a diplopia and Hess chart. Post-duction and test is probably the most important clinical test which you will do in these patients, even more than diplopia. Imaging is important, and probably MRI scan is more helpful, which shows disease activity. It also shows the typical tendon sparing muscle enlargement and inflammation, and also gives pointers on optic nerve involvement if there is any. Very infrequently, but CT scan of orbits or ultrasound also can be done, though it's not as useful as an MRI. So here you can see an MRI picture which shows a very typical tendon sparing. If you see here, there is a tendons are spared here, but there is a fusiform enlargement of the muscles. These are the differentials when you are looking at thyroid eye disease, and a lot of times clinical picture is more or less self-evident, but sometimes, as I mentioned earlier, in a silent thyroid eye, you can get confused with any of these entities here. coming to the management, the non-surgical management probably is required in patients who have either an active disease where there is an inflammatory pathology going on still, angles are not stable. You would probably still look at medical therapy to look at to not only control the other parts like proptosis and all, but also to give him symptomatic relief from diplopia. So from the strabismus point of view, this is the time where you may think of the botulinum toxin, because at this time the muscles are not tight and fibrous and they are inflamed, but not really the tight cord-like muscles which you see. So probably you can look at botulinum at this stage when the patient is in the inflammatory or early labile stage of the disease. And of course prisms. And coming to prisms, you can give both Fresnel as well as ground in prisms. They are definitive treatment for small angle deviations. Prisms are an option even in the late fibrotic phase if the angles are small enough for you to deal it with the prisms. But while if you're looking for very large angle strabismus, then probably you can give them temporarily while you wait for strabismus to stabilize. As I said, botulinum toxin has a role in a very, very limited small area where there is only inflammation and not much fibrosis. And poor patients who are poor surgical candidates, you can offer that. Those who are unwilling for prisms or do not can also offer it. Only problem is here is recurrent injections are required, and dosage is to decide the dose, and to difficulty of delivering the dose because the muscle is really bulky. It's a very friable conjunctiva. So this option probably is fraught with other difficulties, technical difficulties of actually giving the injection. But this probably you can think of in the early stages of disease when you don't want to do surgery. Now surgery indications, any intractable diplopia in primary gaze or in down gaze, you need to treat it. You need, if there is an abnormal head position, you need to treat that eye also. And in cosmetically unacceptable situations also, you may have to go in and do the surgery. Challenges here are variable outcomes, very tight muscles, friable conjunctiva, and incomitance. Sometimes there can be an incomitance in primary and down gaze itself, which allows you difficulties in calculating the surgical dose. But here, the clear surgical goal should be to achieve enlargement of the binocular single vision field, and probably you have to pick up and choose your angles for primary gaze and in down gaze, because those are the more practical fields of vision. When it comes to surgical dose, this is a dictum that lot gets you more and little gets you a lot. Smaller angles often need larger recessions, and larger angles often need smaller recessions, and this must be kept in mind when you are planning a surgical dosage for these patients. Timing of the surgery is usually during the inactive phase of the disease, when the angles have been stable for a while. And if any orbital decompression has been planned, then strabismus surgery should be done only after an orbital decompression, because orbital decompression itself can produce a new strabismus, as well as it can modify the old strabismus in a way which you did not anticipate. So timing of surgery is always post decompression. And of course, you can use MRIs, serial MRIs to look at muscle edema, and that is a marker for activity of the disease and instability. And if you really see a very enhanced muscle, you probably would want to not do surgery at that stage. So as I said, surgery, you have muscles are very tight, so recessions are always technically simpler and probably give more bang for the bucks. Resection is better avoided as a first surgery, but there is this, I found this article there where you can think of resections if already some amount of large recessions have been done as a secondary procedure. You can look at resection of ligation if there is a residual esotropia or hypotropia after you've done the maximum recession. Adjustable sutures is a little bit of a controversy here. There are literature, if you do the literature search, there is evidence on both sides that adjustable sutures improve the outcomes, and then there are where adjustable sutures have been associated with late overcorrections. So I think here you should probably do what works best in your hands. And this is my personal thinking. Inferior rectus, probably it's better avoided adjustable suture and better to put a fixed suture, because this is the muscle which is most prone for producing late overcorrections as the time passes. Another advice is to probably use a non-absorbable suture like Dacron or something on these patients, or especially in inferior rectus, where it gives probably avoids the late slippage and late overcorrection in a very bulky muscle. Patient counseling is important. Realistic expectations have to be explained to the patient. You have to sometimes proptosis, which is not very obvious, can become obvious after surgery. So this needs to be talked to these patients, especially if you are going to remove recessed too tight rectus, which is often the case in these patients. Proptosis is likely to increase, and multiple surgeries also need to be counseled even before you plan for surgery. During intraoperative considerations, if you have to look, then forced reductions are your friends in every way. Large muscle recession should also be combined with a conjunctival recession to avoid postoperative restriction because of the conjunctival tethering. Dissection of Tenon's capsule, especially around the inferior rectus, is very, very important. With adjustable sutures, as I said, concerns are slippage, scar elongation, and progressive overcorrection. And a lot of these intraoperative tensions may also come because of a very, very friable conjunctiva. And you are likely to encounter pulled into syndromes because of very, very tight muscles. So you need a special hooks like a right hook or a Wilson hook or a double hook to use. Again, muscles can be very tight, and you may have difficulty in inserting your scissors to cut the muscle of the sclera, and sometimes you may actually have to use a 15-degree barbed pucker knife to cut the muscle. So these are two instruments which are very, very useful in these situations. This is a Fechner's forceps, which you can see the tips are very have no points, but actually two rounded things, which help you to keep the conjunctiva from tearing and buttonholing the conjunctiva. Because if you have buttonhole conjunctiva in these patients, especially patients who have been smokers, it takes probably less time to do the surgery and more time to suture the conjunctiva. So please be very, very gentle and with conjunctiva in patients with thyroid ophthalmopathy, especially those who have been smokers. There is another muscle technique which has been described, which is kind of holds somewhere between adjustable suture and a fixed muscle surgery, which is called as intraoperative relaxed muscle technique, where you disinsert the muscle and you let it slip back to whatever position it is, and you attach it to that position wherever the muscle comes to rest in this technique. And preoperative deviations are not taken into account in this when you are deciding the recession in this kind of technique. And it has been described, and with fairly good success rate if you review this paper, which was published in 2006. So as I said, these patients need much less surgery. Sorry, the photo has been reversed here. I have actually done the left eye surgery only. But when I measured this patient, he had almost a 55 prisms of hypotropia in the left eye. And all I have done is just about 5.5 millimeter of inferior rectus recession. And as you can see, he was free from diplopia, and alignment looks pretty good for that large angle with just a single muscle surgery. And he was a smoker, and you can see the amount of bleeding and conjunctival damage which seems to be there in the picture. These are the complications which have been commonly seen with these patients. Overcorrections and undercorrections are mostly overcorrections, that to late overcorrections. lower lid retraction, and A-pattern exotropia. So overcorrections happen because of the gravity, especially with inferior rectus recession, because of the gravity and subclinical postoperative inflammation, slippage, and also increased in the ipsilateral superior rectus joint. Eyelid retraction, again, attachment of the capsulopalpebral head is to the inferior rectus, and a good careful dissection can reduce this, but it is impossible to avoid it if you are planning for a larger inferior rectus recession. A-pattern exotropia, especially very common after bilateral inferior rectus recessions, and this can be tackled by either reducing the amount of medial rectus recession if it is planned, and delaying medial rectus recession if it is simultaneously planned to do another sitting, and also to nasally transpose the inferior rectus can also help it to offset this. The frequency of reoperation in this as high as 50%, so these patients need surgical follow-up, and you must not leave them just because surgery is done and you are done with them. So to summarize, surgery only functionally and cosmetically disabling, quiescent stage, conservative therapy trial should be given for every patient before you plan surgery, and cessation of the smoking and hormonal control of thyroid is very, very important to get a good surgical outcome. Standard surgical nomograms do not apply, and probably you have to titrate your own dose in some way. You can use a relaxed muscle technique, or you can use a adjustable suture, or you can, but whatever works. Almost always you will get more effect if the angle has been very large. So you must titrate your result based on experience. Post-duction test intraoperatively is absolutely essential whenever you do the surgery. Recessions are preferred over resections. Adjustable suture with a question mark. So in conclusion, strabismus surgery in thyroid eye disease is challenging. Careful planning and meticulous surgery almost always improves the outcome, and counseling regarding realistic goals and unpredictable outcome is absolutely mandatory to avoid litigation as well as unhappy patient. Thank you for the attention.
Thank you, Dr. Sumita. Nita, you have questions?
Yes, hi. Hi, Sumita.
Hi.
I have two questions.
Sorry to interrupt. Meanwhile, may I request Dr. Abha to be ready with her presentation? Abha? Dr. Abha? Go ahead.
Yeah.
Sumita, when we talk about using Botox for these muscles, since the muscles are different, would our dose change? Would it be the same, or would we, if I say you use 5 units for a medial rectus in a lateral rectus palsy, would it be about the same or would it be more? Second question is, in your personal experience, since there isn't too much thyroid like you rightly said, in your personal experience, would you use non-absorbable sutures more and more, or do you tend to use absorbable and put them on a
No, I honestly have, in 1 or 2 re-ops I have used, but primary I have still been using Vicryl. Regarding Botox, I personally have no experience on Botox in these patients, but I have always felt that it is technically very difficult to deliver the dose in muscle. Conjunctiva is friable, and to hold the muscle, even if you are not really hooking and really going through the conjunctiva only, but probably in the early phases, and probably your doses should be just about the same. 2 to 2.5 unit probably is what I would do. I would put if I have to.
So do you open the conjunctiva, do you expose the muscle and then inject the Botox?
In adults, probably it's not required, and especially if you are doing it for medial rectus. Inferior rectus, probably it's better to hook in or do it under EMG cover.
Okay. Have you ever had overcorrections in strabismus cases in thyroid when you walk?
Yes, I have had. A lot of times, I'll tell you the commonest scenario where the overcorrection happens. It may not happen in the primary gaze, but if you do a very large recession, often in the reading gaze over a period of time, that eye will become hypertrophic because of increased tone of the superior rectus muscle, and patients complain of difficulty in reading or torsion in the down gaze. And this is a problem which I have encountered in at least couple of my patients who did well for a while with thyroid eye disease, and overcorrection, again, they stayed okay in the primary gaze, but in the down gaze, the previously hypotropic eye was actually hypertropic. And I had to give prisms in one patient. One patient we did counsel him for surgery on pardon on the other eye to match the duction deficit. But sometimes that is the one. So when we see angles of 55, 60, we all tend to do 6 millimeter medial inferior rectus recession, and then plan it with another medial rectus recession because they will base a lot of. But probably I burned my fingers and I don't do anything more than 5, even if it is very large angle.
Do you nasalize them, if the inferior rectus? Even
yes, if it is bilateral, then yes, not on single.
Dr. Sundena, you want to say something?
Do we have time?
Yeah, we have time.
Sumita, I just had a question. If you have exophthalmos and a squint and a strabismus, what would you do? Would you wait?
No. Yes, if it depends on what the patient. If a lot of these diseases are like multidisciplinary approach, and you have to work in tandem with the orbital surgeon. So if they are planning to do something for the proptosis, I'm going to wait for strabismus surgery and try all the other things which I said. You can try prisms, you can try occlusion if the prisms are, sometimes the angles are very large and patients just don't fuse. So, or if it is early and if I have access and I feel I will be able to give Botox, those are the 3 strategies in stages where it is not going to, I'm not going to plan surgery. But yeah, another factor which decides on my timing of surgery is, of course, how bad the muscles are inflamed. So the decision to operate comes via orbital surgeon rather than me taking it. I do take care of their diplopias, but I may not operate unless it's a go ahead with from orbital surgeon.
And obviously, the endocrinologist also would be involved.
Yes. Endocrinologists are often involved because, as I said, outcomes, general well-being of these patients is that you should get their thyroid levels under correction, even if they directly does not correlate with your strabismus or thyroid eye disease. But you must always remember, these patients are often very they are very disturbed patients. They are actually need a little bit of counseling, and patient their appearance changes, their
I can never forget that.
Yeah, they have diplopia and they are relatively not very old, and it is very, very disturbing for these patients. It's a very terrible disease. Nobody should have it.
Dr. Abha, are you ready?
Yes, she is. I think she stopped screen sharing. She was sharing the screen up till now.
Dr. Abha?
Yeah. Hello, I'm ready.
You can start then.
Hema, how many more talks to go?
Just Dr. Abha, and then we have one more.
Okay, perfect. We are in good time.
Hello, good evening, everybody. I'm really thankful to Dr. Samant Square for giving me the opportunity to speak on the subject. My topic is monoocular elevation deficit. I will be discussing this topic under these headings, that is definition, clinical features, etiology, management, that is investigation and treatment, complications, and the cases. As we know that it is a unilateral deficit of elevation which is associated with variable amount of ptosis. We know that the oculomotor nerve has 2 divisions, that is superior division and the inferior division. The superior division supplies to the superior rectus and the levator palpebrae superioris. And the defect of this superior division is going to produce monoocular elevation deficit. The clinical features, you will find that there may be abnormal head posture. It may or may not be there. You'll find ptosis which may be true, pseudo, or mixed type. Elevation deficit will be there, and it is very specific in monoocular elevation deficit that it is present in abduction in primary position as well as in adduction. You should always look for the Bell's phenomena and the forced reduction test. As far as the abnormal head posture is concerned, you can see that this patient had a minimal hypo. So with slight amount of chin elevation, he can fuse both the eyes. So this type of patient will have definitely a abnormal hypo, that is chin elevation. But look at this patient, he had a complete ptosis and there is very much hypoabdominal. So this patient will not have any abnormal head posture. As far as the limitation of elevation is concerned, as I have told you, that there is limitation of elevation in abduction, in primary position, and also in adduction. You should differentiate whether the patient is having true ptosis or a pseudotosis. As Dr. Yogesh Naik has described, that when you close the normal eye, there is still ptosis present. That means it is a true ptosis. But when you close the normal eye, the eye elevates and ptosis disappears. That means it is a case of pseudotosis. As far as the etiology is concerned, there is most of the time it is congenital and acquired. The congenital, it may be of supranuclear defects or it may be infranuclear defects. In acquired, usually the patient has other systemic elements as well. In the primary superior rectus paresis, you will find that the FDT is negative. The Bell's phenomena will be absent, and seconds above the midline, they are defective. 50% of patients with monocular elevation deficit with hypertropia in primary gaze have superior rectus paresis. The primary inferior rectus restriction is also a cause for elevation deficit, and in this you will find that the FDT is positive, and there will be absence of hypo in primary gaze because the superior rectus is able to put the eye in the primary position. The upward saccades may be normal. The main differentiating feature between the supranuclear and infranuclear palsy is that in supranuclear palsy, the Bell's phenomena is present, and in the infranuclear palsy, the Bell's phenomena is absent. You see this patient, this is showing, you can see, sorry, yeah. You can see that the Bell's phenomena is absent in the right eye. Sometimes in congenital, this patient had a congenital elevation defect, but there was no deviation in the primary position. But when the patient looks up, you can find there is a crease of near the inferior lid margin. So there may be some attachments which are affecting her elevation. We will observe this patient because there was no deviation in the primary gaze. In the primary gaze, there is no deviation. So we'll wait for this type of patients. Our goal is to improve the eye position in the primary gaze and to prevent the amblyopia. Various procedures are NAPS procedure, that is a horizontal transposition of the medial and lateral, vertical transposition of the horizontal muscles near the superior rectus. You can do full tendon transposition or half tendon transposition depending on the amount of deviation. You can also do posterior fixation suture to augment the transposition of horizontal recti. Following the spiral of telex, it gives a good results. You can do superior rectus resection in less than 25 PD hypo and upgaze ability above midline. The treatment, as I have told you, that we will decide the treatment depending on the result of the FDT. If the FDT is positive, you cannot only undergo NAPS procedure because your tight inferior rectus will prevent the elevation. Now the NAPS procedure, it can be done with the variations of tendon placement. You can put it obliquely as well. You can in the line of the circle of the spiral of Tillex, or transpose the muscle perpendicular to the superior rectus, insertion of the superior rectus. I am showing you the surgery. Yeah. First do the force reduction test, then you suture the medial and lateral muscles, and then cut the muscles from the insertion. And this is the superior rectus muscle. You are going to attach the muscles on the lateral and the medial side of the superior rectus. And then suture the conjunctiva as well. You can see that this is superior rectus and there are sutures. I'll skip the slide. This is another. You can see that there is a FDT is positive. The patient had tight inferior rectus. So we did inferior rectus recession. It was done by the hangback technique because it is always better and comparatively simple to do the inferior rectus by hangback technique. Then you suture the medial and lateral muscles, and then in this case, it was done in the insertion, in the line of the insertion of the spiral of Tillix in this fashion. And the conjunctiva is suture. Then we will see some of the cases. This patient had ptosis. You can see the large amount of ptosis. There is an hypo in the primary gaze, which is there in abduction as well as primary position and adduction as well. This is after the surgery, after doing the inferior rectus recession and the Bell's and the NAPS procedure. You can see that it is almost in the normal position. Actually, this patient required ptosis surgery as well. And as we are aware that the patients from village, we have a poor follow-up. When I came to know that he's undergoing the ptosis surgery and he didn't come for follow-up, so I wanted to record his movements. You can see that there is quite a good elevation. Before giving anesthesia, I asked them, let me take his video. There is good amount of elevation. This patient had the MED and we did only NAPS procedure. She was hardly 13 or 14 years of age, but she allowed us to do it under local anesthesia with just a vocal consultation, and she allowed us to do. So I remember this patient. You can see that her elevation has definitely improved. You see this patient, this on NAPS procedure with inferior rectus. There is good amount of elevation which occurred after this. This is a very unique patient because, in one eye he had monocular elevation deficit and in the other eye he had advanced retraction type 1 syndrome. You can see that there is no elevation in abduction in primary and in adducted position, and limitation of lateral rectus in the left eye as well. So we did, this is just a pre-op photo of this patient for pre-op elevation deficit in all the 3 gazes. And this is after surgery. Right eye, we did inferior rectus recession with NAPS transposition of the horizontal recti to the vertical muscles. And in the left eye, we did Y-split, and the elevation has definitely improved. It was because this elevation has also improved, so there was not much of the upshoot seen post-op. This pre-op. Actually, that elevation of the left eye was more obvious because of the right eye elevation deficit. This patient had complete ptosis with total third nerve palsy. Yeah. You can see his pre-op. I'm sorry, it was not total. It was superior division palsy.
Dr. Abhay, you'll have to summarize.
You can see that there is good amount of hypoptosis. The patient has to elevate the lid to see the movements, to record the movements. And we did first the horizontal transposition, vertical transposition of the horizontal muscles. Still there was hypo. Why we did vertical transmission first? Because there was no...
Dr. Abha, you will have to summarize, please.
We thought that it will improve, but it didn't. So in the second step, we did the inferior rectus recession, and you can see the good amount of effect after the second surgery. And the patient had to undergo the ptosis surgery, and this is just a post-op photo after the ptosis surgery.
Summarize now. Abha, please summarize.
I still sometimes don't understand why even a full transposition of the horizontal muscles, that is, the adduction and abduction are full. They are not at all affected.
Abha, you have to summarize.
You can see the elevation has definitely improved. There can be complications like undercorrections, overcorrections. There may be changes in the lower lid. In tight inferior rectus, it's very risky. So you be careful.
Abha, stop your slides, please. Abha, you have to summarize. You've overshot your time.
Hello, madam.
Yes, you overshot your time. You overshot your time. Please wind up.
Hello, what happened?
You have to wind up. The time is
there
over.
May be corrections, overcorrection. In tight inferior rectus, be careful while dissecting the muscle. Anterior segment ischemia is possible in adults, so don't operate 3 recti in the same sitting. There may be
Abha, I'm requesting you to please stop. Stop.
Madam.
Please.
Madam, summarize करना है. Summarize. Stop.
We just called her up and told her.
Okay.
Where is she?
Now she's gone, I think.
I'm summarizing that it is in monocular elevation deficits. You have to choose the surgery. Most of the time, the patient comes with the complaints of the lids, that his lid is not elevating. You have to explain it to the patient that it is not the problem of the lid, it is your eyeball. So you have to operate that patient for the position of the eyeball, and then subsequently the patient will need more surgeries. So you have to explain. Complete counseling is more important in these type of patients, because most of the times you require 2-3 surgeries for the...
Dr. Abha, you have to summarize.
Because you have to give the session to the next speaker.
May I invite Dr. Shailaja? Shailaja, are you here?
Yes, Dr. Himalini.
Can you share your screen, please?
Yeah. Am I audible?
Yes, you're audible.
Abha, stop your screen share.
All right,
Abha, stop your screen share. Yeah. Go ahead, Shailaja.
Hello.
Yeah, thank you, Dr. Himalini and Professor Malik and Maharashtra Ophthalmic Society for giving me this opportunity. If I'm not clear, just let me know. My voice is not quite in the best of shape. So I am here to discuss about DVD. I call it a mystery phenomenon because till now it's not very quite understood by the entire strabismus fraternity. So it was first described by Schwiger and then by Stevens, but it was detailed. The description was provided by Belchovsky in 1931. It has been termed by varied terminology, so you can understand what is the underlying mechanism is not very quite understood. So it has been termed as double hypertropia, double hyperphoria, alternating hyperphoria, or dissociative vertical divergence, and so on and so forth. And why is it so? By just looking at this video of the DVD, it is not like what you would expect when you normally uncover an eye. So you can see when you cover the left eye is coming from up, down. And when you cover the right eye, that also comes from up, down. So in true hypertropia, one eye should come from up, down, and other eye should come from down, up. So this is a disconjugate hypertropic deviation. The movement is quite slow. It can be seen better with this Spielman's occluder, which is a translucent occluder, and it is seen better with the in the non-fixing eye. So it's a deviation of the non-fixing eye. The eye that maintains fixation remains straight, and only the eye under the cover will move underneath it. So this is a cartoon to show the differentiation between hypertropia and DVD. As you can see that the right eye is hypertropic. So when you close or occlude the apparently fixing eye, the fixation movement is right eye is downwards to take a fixation, and there by Hering's law in the left eye there would also be a downward movement to take a fixation. This is the conjugate movement that will happen. So when you then shift the occluder to the right eye, now this left eye will take a fixation, so it should move from down up to take a fixation. While in DVD what happens is when you close the apparently fixing eye, the eye which was in the manifest DVD will come down, but there will be no hypertropic movement of the covered eye. In fact, when you move the in fact, under the cover, this eye can go up again in DVD because DVD is usually bilateral. And when you shift the cover to the other eye, then this will come down, and again there will be no movement of the covered eye, or again it can go up. So both eyes under the cover will go up. So this is a disconjugate movement between the two eyes. Often there, along with the vertical movement, there is also torsional movement, and also a movement from outside in, which is an exotropia to inside movement, which the torsional movement can be appreciated in this video. So no one really knows what is the etiology. There is a lot of theories around it. So there is an error in torsion in the fixing eye. There could be apparent impulses from the vertical divergence center. Recently, a scleral search call recordings have shown that it is a mechanism actually to dampen the latent nystagmus, which is quite commonly associated with this condition. But in many cases, the latent nystagmus is not there also. So what happens in them, it's not known. Brodsky kind of linked it to the dorsal light reflex, which is an atavistic response seen mostly in fishes. Most commonly, it is seen when there is disruption of fusion in very early age, that is in infancy, and so it is more commonly seen in infantile esotropia and infantile exotropia. But any congenital onsets like MED, Duane's, all may have a DVD along with it. In acquired cases, mostly it is seen after long-standing vision loss, like sensory heterotropias. It has also been seen with accommodative esotropias and intermittent exotropias as well. It can be manifest or latent, and it's very important to note it because it has a bearing on the treatment. It is more than often bilateral. If you see DVD in one eye, always try to look in the other eye, and you have to really occlude it for a longer time to reveal the DVD. And whenever it is bilateral, more commonly it is asymmetric, and often also associated with latent nystagmus. There are two other typical phenomena which for textbook I'm mentioning here, although clinically not required most of the time. But if you are in doubt whether it's a hypertropia or a DVD, Belchowski phenomenon can be used, where a neutral density filter, when it is kept in front of the fixing eye, while the non-fixing eye is under the cover, if you keep on increasing the neutral density filter, there'll be a time when the hyper eye will become overshoot and become hypo. And the red glass test, where normally in hypertropia, one eye image, when you keep the red filter in front of one eye, the image would be up and the other eye would be down because of the relative hyper and hypo position. In DVD, whichever eye you place the red glass, the image will always be up or down because the eye is always up under the cover. You measure it using the prism undercover test if you want to have accurate measurements. Now here it is essentially like a cover test, but you have to ignore the movement of the other eye. You have to just look at the movement, neutralizing movement of the eye under the cover, and keep on increasing your base down prisms till you finally see no recovery of the DVD eye, or even a reversal. In children where this is not practically possible, or in patients who are not cooperative or those with sensory deviations, you can actually use the Hirschberg light reflex, where you have to just grade it mild, moderate, severe, depending on the degrees of hypertropia which is seen. It's very variable. You have to remember this. It may depend upon the patient's tiredness, whether they are daydreaming, and it may increase or sometimes even decrease when the child is fixating on the vision chart. Depends upon the attention span and concentration. It varies from day to day whenever you measure them from various visits, and quite often it is more marked on casual observation. When the child is just gazing far or daydreaming, it is much more marked, and you can see the maximum amount of DVD then. So a reverse fixation test is used to measure the DHD. I'm not going to detail of this. Grading is basically different points, like you can have a small, medium or large grading using several papers. You can have a 4-point scale where less than 5 degrees is grade 1, 5 to 10 is grade 2, 10 to 15 or more than 15 is grade 3 and grade 4. And even the control of the DVD can be graded like good, fair or a manifest DVD. Now, coming to the management of DVD, first and foremost, try to give the patient the maximum best possible vision, because good vision is in itself a good stimulus to control the DVD and make it less manifest. So treat the cause of the poor vision, give refractive correction, treat amblyopia if it is there. But it will not improve with time, but it may just come under the control. The surgical indications, first and foremost, is the manifest DVD. Now you have to remember that whatever surgery you do, you may not be able to abolish the DVD completely. So the aim is to improve the cosmetic appearance and make a manifest DVD into a latent DVD. DVD can occasionally lead to head tilts or turns, so that can be treated and could be an indication for surgery. And very large DVDs can actually give ocular discomfort when they get manifested. And in small children, it is a independent risk for developing amblyopia. So approach to surgical management, it depends upon the grade of DVD, how much is the DVD, and also the incompetence of DVD. Incompetence means how much it is differing from the from the primary position, and more than 7 prism diopters on either side is an incompetent DVD, and associated oblique dysfunction will determine the approach. So a simple competent DVD, you have to do a bilateral SR recessions, and these are larger SR recessions than recommended for a simple hypertropia. Incompetent DVD, you have to see which gaze it is incompetent. If it is more in adduction and there is inferior oblique overaction with a smaller DVD in abduction, go for IOAT. If more in adduction, IO overaction, but moderate DVD in abduction, you may have to do both IO weakening as well as SR recession. And if it is more in abduction, plus there is superior oblique overaction, you have to do a superior oblique weakening procedure to address the A pattern associated with it. But remember that the DVD will increase if you do a superior oblique weakening procedure. So you have to combine it with a superior rectus recession, again large superior rectus recessions. So just a couple of cases. So this is a competent DVD, similar in side gazes and almost symmetric DVD in both the eyes. So this patient underwent a bilateral LR recession for the XT and bilateral SR recession 8 millimeters for the DVD, and obtained a good result. We have published our results of bilateral symmetric and asymmetric superior rectus recessions for DVD of 27 patients. This is an Asia Pacific journal, and we did 5 to 10 millimeter SR recession. The concern with SR recession is large SR recession is that they may develop lid retraction, upper lid retraction, lid fissure changes, and also a V pattern in upcase, which can be avoided. But in our series till 10 millimeters, we did not have these complications, and success was seen in 63%, which was no manifest DVD. So when in cases with DVD where the DVD is more in adduction like this with inferior oblique overaction, bilateral MR recessions with IOT were done, and quite good results were there. And this is a patient where PTSO was done along with the superior rectus recession. And so case series have been published from our center as well. So some of the surgical pearls which I want to highlight is that whenever you do a unilateral DVD, a unilateral surgery, you have to be sure that the other eye will not take up, that the DVD eye where you're doing the operation will not take up fixation. Unilateral surgery should be reserved for those who have no chance of fixation and predominantly unilateral DVD. Otherwise, the DVD of the other eye will become manifest after you do operate on one eye. So always carefully look for bilateral DVD, and if it is asymmetric, and go ahead with asymmetric DVD surgery. And if there is a true hypertrophy associated with it, it is often seen with long-standing DVD where the superior rectus contracture develops, and here you have to increase the dose on the hypertropic eye. This I've already mentioned, that you can prevent the lid fissure changes by doing a meticulous dissection, dissecting out the intermuscular septum, the attachments with the upper lid, and also with the superior oblique, the frenulum with the superior oblique. And you can nasalize the superrectus if you are doing large recessions to prevent incompetence. And IOAT, be careful of the anti-elevation syndrome. So don't forget to bunch up the insertion when you are doing it. The complications of DVD surgery is mainly, I would say only one complication is the main important, which is residual DVD. So once you have done one muscle, you can tackle the other one. Like if you have done IOT, you can do the SR recession or vice versa. You can do a Farden on the SR, although it's very technically difficult to do a Farden on an SR. IR resection has also been advocated. And to prevent residual DVD, especially the DVD is large, like beyond 15 prism diopters, it has been advised to combine it with both the surgeries and the first go, or do extra large SR recessions, or even IO resections with IOAT. So these are the references for those. So finally, to conclude, one needs not to be beware, but be aware of dissociated deviation while examining squint patients. And again, as highlighted by so many other talks, counseling of squint patients can never be enough. These patients are bound to have residual or recurrent in many of the cases. So you have to counsel them for need for multiple surgeries. Thank you.
Thank you, Dr. Shailaja, for a wonderful presentation. Due to shortage of time, I'm not going to take any questions except one that, like you said, I think a very important take-home pearl was that if you get, beware of asymmetric DVDs. Because very often when you counsel the patient for one surgery, the other eye starts going out. Nipa, you want to make one last comment on what Shailaja, on Shailaja's presentation before we wind up?
Shailaja, very well said. In a two-sentence nutshell, do you have any sense of what sensory changes happen after you correct your DVD? I mean, one indication you said clearly was cosmetic, but do you have any sense of if you're getting any sensory improvement as well?
Yes, we do get sensory improvement as well. Although we could not analyze it much, because the proportion of patients achieving a sensory is very less, because most of them have infantile esotropia or infantile exotropia along with it. And DVD comes later on. So when you have not operated them at younger age, the sensory restoration is not that great. But yes, a gross stereopsis like 2000 or 300, 800 seconds is seen in quite a lot of our patients.
Thank you, Shailaja. We'll have to wind up, Nipa. Thank you, everybody. Thank you for this wonderful session. Thank you.
Thank you.
Hello, Dr. Deshpande sir. Unmute yourself. Dr. A. Deshpande sir, unmute yourself. Hello, good evening all.
Good evening, sir.
Good evening. I request our chairman sir, Dr. Anand Deshpande sir, to unmute himself so that he will be audible to all of us. Hello, Dr. Deshpande sir. Okay. I invite all of you for this medico-legal symposium. It has been designed wonderfully by our chairman, Dr. A. Deshpande. I think.
Marathi.
Yes, sir. Please, welcome.
Please ask him to start my video.
Sir, you will have to do yourself. Yeah.
No, he has stopped it. Start video. Host has to start.
Host, please.
Host.
Start video of Dr. Deshpande, sir.
Yes, host has to start. Who is host?
You are the host.
Are you able to hear me? Prakash?
Yes, sir.
Are you able to hear me?
Hello, Mr. Akhilesh Kulkarni, are you here? Akhilesh, yeah. Viral, yeah. You can start.
Deshpande sir is the host now. Deshpande sir is the co-host. We can start now, sir.
No, but my video is not starting.
And it's from your side only.
Host, Malik madam.
Madam, sir, left hand side.
Yes, that is true, but host has stopped. Host has to start.
Yes. It is in, sir. Yes, sir.
Now it is.
Now you are muted yourself. You unmute yourself now. Sir, your audio has stopped.
Now, here? Are you able to hear?
Yes, sir.
Yes. Welcome to all. We will start our meeting though a little bit late because was going on for a little more time. I welcome you all for the symposium. now I will hand my mic to the Prakash Marathe.
Hello. Good evening all. I think it is a wonderful conference organized by Maharashtra Ophthalmological Society in this COVID era. And I think it is a virtual conference. All of us are not able to meet physically, but on this virtual platform, we are able to meet. And this is the need of the hour. That is a medical legal symposium. It has been very well designed by our chairman, Dr. A. Deshpande sir. And I request Dr. Deshpande sir start with this topic. And that topic is very much apt. Recently, CPA, that is Consumer Protection Act, it was amended. A little bit different changes were done. All of them were not in favor of medical fraternity. So, biting teeth, COVID Act 2019. Dr. A. Deshpande sir, please.
Welcome to all. Really speaking, there was this act was there previously also, but because previous act was totally peeled off, means cancelled, and a new act has started. It has a little big biting teeth. And about that only I am going to speak about in detail.
Can you share your presentation? Can you share your, yeah, it is Neha Deshpande screen. May I request Dr. Neha to stop screen sharing, please?
Yes, sir.
Neha, band kar.
And you can start sir's presentation.
Share. Yes, able to see?
Yes, sir. Yes, sir.
The act of, that is called now this act of 19. And this act is totally different from previous, because previous act has totally stopped and it is repealed. So the new act, it started from 20th of July and it is applicable now to whole of the India. The Consumer Protection Act 2019, Chapter 1 point, that is in second say that 42 is its service. They have mentioned service. There was a very big thinking that because it was not mentioned actively, in that it was taken from many our people that we are exempted from that, but it is not true. The provisions of the facilities in connection with the banking facilities, insurance, transport proceedings, supply of electrical or other energy, but does not include the rendering of the services free of charges or under the contract of personal services. But what they have done, but potential users are included. So they have not limited to this word they have used, and because of that word, all the services which are not mentioned in the act, the act is applicable to it. What is the previously? Previously the limit was of the 20 lakhs at the district level, 1 to 10 crore, that is 20 lakhs to 1 crore at the state level, and at the national level it was 1 crore. But now it has totally changed from 20 lakhs to 1 crore. Means 1 crore is not the limit of demand. Previously it was 20 lakh was the limit of demand, but here the limit is not of the demand, but limit is of bills that you have paid. And up to the paid bills, means any hospital has paid, if up to 1 crore, the patient is able to put the case in district forum only. And from 1 to 10 crore, it is at the state level, and from the 10 crore above, it is at the national level. From this act, it clearly indicates that no hospital can do a bill of 1 crore. So this act is now formed, taking in front of as a whole builders, companies and traders. And so they have increased the limit, because in Delhi or some big cities, if a transaction of a one flat is there, it is more than 1 crore. So they should be able to go if it is in between the 1 crore, they should be able to go at the district place. So this act is made like that only. So this is expanded not for medical jurists, but it is also applicable to us. So it has become very difficult for us. Another thing is that all the in area the cause of action, that is a district, state or national consumer redressal commission area as per limit of the demand. Previously, where the incidence cause of action was started, that was the place where the case can be lodged. But at present, at the cause of action or at the place of residence or workplace of the consumer patient, or it can be online. So a person who has taken from the Karnataka or a Kerala, who has taken the treatment in Delhi, can lodge a case in the Karnataka or Tamil Nadu, wherever he is working or wherever he is sitting. So the doctor has to run to that state, go to that court and apply and represent himself. So it is become very difficult for doctors to appear in the courts. Appeals, previously 25,000 was the limit that much used to be deposited in the court for to do the appeal. But now the limit of and it was 30 days limit, but now it has 50% of the order amount. So whatever is ordered by the lower court, that 50% should be deposited in the court before you go for the appeal, and the time period is increased from 30 days to 45 days. The judges and staff was appointed by the judiciary. So there was a genuineness of the cases and pleading and everything. But now their provision is that according to clause 29, the judges and staff will be appointed by the central government. There is a very likelihood that so any person can come and sit in the and sit and give the decisions. Are you not able to hear me? You are able to hear?
Yes, sir, you are audible. No problem.
Audible, yes. The new clause, that is 36(3). If the complainant is not heard in 21 days, then it will be taken as admitted. Previously, after the hearing, complaint was admitted or discarded there only. But now there will be very big rush in the courts, particularly in district courts, the consumer commissions, and so every case lodged will be defined and it will be there in the court and it will not be dismissed. Clause 37(1)(2) and clause 74, after first hearing, the complaint referred to mediator. So this is a new clause. Mediation was not there previously in Consumer Protection Act, but now it has started. But this mediation is a good thing or a bad thing. It is to be decided according to the people that take the benefit of that, because the mediator is able to do the mediation and settle the case if both the parties are there. So what will happen if it is done in good faith or the mediator is really impartial? Then it is a very good thing. But if he is not so, what will happen? An advocate will go to the patient and will say that sign here and go away. I will see that you will get some money. And the patient thinks, what I have to do? Nothing, just sign and go. And the advocate will put that case and will ask for the compensation of 1 crore. And when the case is referred for the mediation, the advocate will compromise it 5-6 lakhs also. And because doctor will think that instead of running the case, giving the advocate and all that and appeals everything, why not to settle for 4-5 lakhs and get away of the case? So he may accept, and if he accepts, the money, easy money, goes to the patient and advocates. So this is a real way of easy money, official legal easy money to advocates and patients, for which the doctor has to suffer, and so it may happen. This mediation clause is dangerous from that point of view. The clause number 74(1)(2), consumer mediation cell. So this is also the same. The clause 49(2) and 59(2), any terms of contract which are unfair to consumer can made null and void by state or national commission. So this is also a very dangerous clause. So previously, whatever terms and conditions were made in between the patients, they were agreed and they were accepted by the consumer courts. But now they are given special authority that if the causes mentioned are not in favor of the consumers, or if they are very bad for the consumers, that can be automatically cancelled by the court, and they can make it null and void, means totally of no effect. Clause number 35(1)(2), product liability action may be brought by complainant if defective product, that is service. So this is a very, very dangerous thing. What result? Product liability means the result liability. Here, because the product is defective, the liability is on the manufacturer. Our product is service, and because our product is service, and if it is a defective means that previously negligence was only the thing. But now if they prove that your services were defective, your things, reports were not correct, or your reading of the report was not correct, or any way, the way you have treated was a defective treatment, the responsibility lies on the doctor to prove that it was not a defective. Previously, the responsibility was of the proving of not done the negligence, and it was a little bit easy. But to say that if the services are not defective is not so easy. So this is a very big biting teeth to the doctors. Another thing is that Central Consumer Protection Authority, to be known as the Central Authority, clause number 15, investigating authority. So this was also not there previously, but now this authority has started. A separate authority is made at the center, and at the state level and district level also their branches can be there. And they are having so much powers to go in any hospital and can do the inquiry of their advertisements, what they are assuring, what they are giving, and what not and what not. So this is just like an income tax person or a factory inspector, that they inspect, and they so much they inspect, and so much they can ask the questions and bring the doctors or hospital in trouble. So this is a clause which can give trouble to the doctor in a long way. Thanking you. So this total chapter, particularly this Central Consumer Protection Authority and mediation clause, these two teeth are very, very difficult for the doctors to handle, and they are going to trouble the doctors at lot things, and the limits are increased like anything. So at the district level also, a patient can ask for more than ₹1 crore, and doctor has to prove that really negligence is to be proved by the patient, but product liability is to be proved by the doctor or hospital, that we have not done any defect in the products. So it is very difficult, and so the new biting teeth are very difficult to tackle with, and that are going to give the trouble to the doctors and hospital. Thank you very much.
Thank you, Dr. Deshpande sir. I think it was wonderfully covered, Consumer Protection Act, by Dr. Deshpande sir. I think recently when the changes were done, as this word of medical service was not included in that particular revision, people thought that medical fraternity, medical community, doctors are out of this Consumer Protection Act. And there were so many rumors that this particular act is not applicable to medical fraternity, but it is not so. Because of that exclusion list, medical fraternity, medical service is not written in that, we are not excluded. So please remember that medical fraternity doctors are still under Consumer Protection Act. And I think with all these remarks, I request our new presenter, Dr. Neha Deshpande madam, who is a medical legal expert. She will be speaking about problems faced in medical practice during COVID. Welcome, Dr. Neha Deshpande.
Thank you, sir. Am I audible?
Yes, you are audible.
Good evening and regards to Dr. A. Deshpande sir, Anil Kulkarni sir, Marathe sir. Today I will be talking on problems faced in ophthalmic practice during COVID. So the first challenge met was when the unprecedented announcement of the lockdown was done on 24th of March, which led to the postponement of all the routine outpatient consultation and the elective surgeries and procedures by 4 weeks. All the non-essential and non-critical examinations, including AR, NCT, syringing procedures, were to be avoided and postponed for the future consultations. The second most challenge met by the health workers and all the hospital staff was switching into the scrubs at the entry to the hospital and again back to the street clothes at the exit. So bath was mandatory once you reach home, which made it difficult for conducting the OPD in the morning as well as the evening. There was a lot of discomfort in breathing by N95 mask, face shields, sweating, lot of dryness and burning to the skin caused by the alcohol-based sanitizers. The challenges faced at the reception were patients were to be greeted only with namaste, there was no handshake. Loss of human touch was also observed because the staff couldn't help the elderly, the patients who were in pain, or the patients who are blind. Separate staff was needed for thermal screening, for taking history, and monitoring the pulse and the oxygen saturation of the patient. Payments were to be avoided in cash, but the patients from rural areas preferred cash transactions, and so all the safety measures were to be taken. There was an additional burden on the registration desk to educate the patients about COVID, also to explain the patients and their relatives about the COVID consent form and get it duly signed. Patient had to be counseled on the phone prior to the appointments regarding the safety precautions which were taken in the hospital. Many patients were apprehensive about getting the COVID test. So they used to inquire whether the COVID test is mandatory even if they step into the OPD for the consultation or if they want to undergo an elective procedure. The biggest challenge which was faced in the waiting area was shortage of the space due to social distancing norms, as is maintaining a 1 meter distance between two patients and also between the health workers and the patients. Shortage of the space as more desks like the registration desk, the screening desk, and the counseling desks was observed. Additional staff had to be deployed to follow the one attendant per patient policy. This caused a lot of inconvenience to the elderly. There was a periodic display of COVID updates to be maintained in the hospital. Additional requirement of the staff for cleaning of ophthalmic instruments was needed. And if you volunteered yourself for the safety precautions, there was a lot of loss of time for the sterilization between every patient. Fogging of lenses was challenging while doing refraction. Because of the avoidance of the tests like NCT, the syringing, or direct ophthalmoscopy, there was chances of missing the findings. Also, the waiting time had to be minimized. There was less communication between the doctor and the patient as less speech was to be observed, which led to incomplete assessment of the patient. Patient who were COVID risk or who were positive bearing ophthalmic emergency were to be referred to the multi-speciality hospital with ICU facilities according to the ICMR guidelines. Privacy concerns were at stake due to the open door policy. The challenges met at the operation theater were all the surgeries were to be a daycare surgery. Additional investigation of routine chest X-ray was advisable, for which the patient had to go to a radiologist to get it done. Surgeries off hours with incomplete staff were to be avoided. To lessen the surgical time to minimum, the procedures which were to be done were chosen as the quickest possible surgical procedure. Topical anesthesia was preferred. Procedures involving general anesthesia were to be avoided. The operation theater had to be maintained with minimum staff to prevent the chances of infection. All the staff had to wear a PPE kit. No positive ventilation was to be maintained. There has to be a gap of 20 minutes between two patients. No two patients were to be entertained together. So this automatically, this reduced the number of the patients to be operated the same day. Protocol based disinfection after each surgical procedure, and a gap of 20 minutes was to be observed. In addition to this, the hazards of sodium hypochlorite, such as burning pain, redness, swelling, and blisters to the skin was observed. It caused coughing and irritated throat because of the aerosol inhalation, irritation to the eyes. The metal surfaces had corrosive action, because of which the chairs and the furniture in the hospital got spoiled. In addition to that, sodium hypochlorite has a mutagenic action. The gas caused a lot of respiratory discomfort. There was less water and food intake because of the PPEs. Fogging of lenses was observed by the spectacle wearers. In addition to that, because of the chemoprophylaxis, there were side effects, and it gave a sense of false security with the gears and the chemoprophylaxis. Last but not the least, low income to expenditure ratio. Patients were less, but more staff had to be maintained. All the staff members, as well as the doctors, had to spend on protective gears. Even the patients who were not carrying their disposable masks, gloves, were to be given from the hospital. Barrier installation of the barriers to all the instruments, slit lamps, all the desks had to be done. The disinfectants were to be used generously. The housekeeping expenses also gone high up, as 2-hourly cleaning of the floor was to be observed. Thank you. Hello.
Hello. Thank you, Dr. Neha Deshpande, for giving a very nice talk. It was really a difficult job to practice in the COVID period because of the gowns, masks, screens, and whatnot. And to stay in the OPD or stay in the operation theater for a long time was really a difficult job and was troublesome also. And so all the practitioners, they suffered it and they have felt it very well. So thank you very much. And she has explained very nicely the things that really the doctors were experiencing.
Very clear.
Now,
Yes.
I will call Dr. Anil Kulkarni. And everybody knows Dr. Anil Kulkarni. There is no need to give any introduction to him. Whole of the Maharashtra knows him well. The post-COVID economical recovery of ophthalmic practice. Because the COVID locks, lockdowns, and so many curfews and so many things. So whole economy of the doctor hospitals has changed and affected. Because lot of overburdens were there, the overheads were there, staff was there, and staff was to be paid, and everything was to be maintained. And in the COVID period, extra precautions and all that, kits and every expenses were so high that the economical balance was totally lost of hospitals and doctors. And Dr. Anil Kulkarni will throw light on that and how it is to be post-COVID, how they should be managed, or how it can be done, will tell you in detail. Thank you. Dr. Anil Kulkarni.
Yes, sir. Desktop now block.
Yes, please.
Yeah, just a minute.
Oh, yes, okay.
Okay, can you see my slides?
Yes, able to see.
Okay. Okay, so basically, Neha has actually gone through whatever we suffered for the last 6 months, and almost everybody. So then that kind of problems really, when we had faced, now is the time for us to realize that we have to do something and try to get whatever is possible out of this bad scenario. Now, basically, as she has very recently said, that the effect of this was the lockdown, which led to sudden drop in the patient inflow. And the senior citizens not only preferred to stay at home, but they were asked to stay at home repeatedly by each and everybody. The surgical work naturally came to near zero because these are the only patients which provide a bulk of our surgical work. And then there were some worrying news and added by social media fear factor, like we call it as a WhatsApp encyclopedia. And then the people started sending rumors also. Unfortunately, that was the problem. Then the steps to prevent and control the coronavirus, as was just discussed, we needed to create more space, we needed to use masks, we had to provide a facility to wash hands at entrance also, and a sanitary use at every entrance, the hospital entrance, the room entrance, the consulting entrance, the OT entrance, everywhere. So there were a flurry of machines which were giving sanitizer for the patients. If I give you my example, till July 2020, from 15th of March, we had to spend 2,21,670. So you can imagine the additional expenses which were unnecessarily required because of this virus problems. And to compound the matters worse, there was a reduced income, which fell down to 10 to 20% for the initial 3 months. Another problem was unwilling staff for reporting to duties because of the fear, or sometimes because one of the relative gets the problems, they were quarantined. And last but not the least was the government threats, so-called guidelines, which were saying that you have to keep the facility open, otherwise there will be action taken against you. And there was appeal to prevent any retrenchment or layoff of the staff, so that whatever staff you had employed earlier had to be given the full pay as well as no layoffs like the industry used to do it. Now, basically, how do we go across for the economic recovery? See, one of the important thing is create standard operating practices for the utmost care by the hospital staff. That means the staff has to be really given the ideas about how to manage themselves as well as the patients. This produces a confidence building, and the patients as well as the staffs realize that there are safety measures which are being taken in this hospital. So some of the problems will go away. Now you have to change the ambience of the entrance, because not only that you are going to follow the recovery steps, but it should be seen also by the patient that yes, this is the hospital which is really taking safeguard actions against the virus transmission, and the confidence of the patients in us will increase, so that they can now say that, okay, I would like to take the treatment. Now, there are a lot of people every day which always say that no, they don't need mask. And if the President of the United States doesn't need it, then why should they need it? But then this COVID readiness and maintaining social distancing and insisting on the mask became a big factor, but then it has to be implemented for the safety of everybody. Like we have shown this standee over here, this kind of standees were displayed at all places in our hospitals. There were videos which were circulated through social media to show how these ways to fight against COVID are being actually implemented in the hospital. Because that creates an awareness that, okay, now it is safe to take the, at least in ophthalmic treatment or even the elective surgeries. The AMCs, or annual maintenance contracts of all our equipments, which runs in lakhs, were fortunately extended by at least 4 months because of the efforts by AOS Managing Committee. But we can now say that every time the people used to say that, okay, the AMC payment has to be given during the start of the AMC. Now you can always do it in installments. There is no question, people will accept it. Once you give them a contract and tell them that, no, we are going to give them at 3 or 4 installments. The vendors and creditors, we are the people who usually pay each and everybody at the end of the month to clear the bills, because we don't like somebody ringing us up and telling that this amount is to be paid. And probably we get not only angry, but we get distressed that somebody is asking the money. Now is the time when we should realize that each and everybody, industrialists and all rich people, feel that they are great because they don't pay in time. We are the only people who pay. So let us start paying them partly, just to ensure that there is an uninterrupted supply of consumables. So and everybody will wait. This was a new experience for me also. But then I realized that nobody even took objection. Yes, yes, doctor, you are right. You can give something and then we wait. Only thing is, just ensure that the loan installments and taxes are paid as priority, because then there are penalties as well as interest on interest, which is likely to be there. And that additional headache over and above our reduced income and extra expenses, we don't want to bear. The banks are giving us some sort of additional advantages of not paying any loan installments, or even the PDCs which were given were deferred for 4 to 6 months. That we should always take the advantage of. So what we are going to see as the road to the economical recovery, there is an overall slowing of economy and reduced payment ability by the patients also. So counsel the patients, discuss with it personally, and whatever is the standard surgical or procedure charges, try to adjust it or discount it depending on what suits that individual person. We were earlier also, and majority of us normally have standard charges, display them and tell them that these are the things which we are going to do. What I found out was, in these situations, people started window shopping and asking other hospitals how much you charge for this surgery, how much is going to be the charge for a type of things which are required for my mother or my father. Then I realized that there is something, people are also suffering. So basically, if we can control and reduce our personal expenses and counsel and discount the charges, probably the recovery would be at least on the right path for the economical thing. Another thing I realized that, let us start telling the people to go for the mediclaim for the insurance companies. When I started getting these cashless cases about 15, 16 years back, I was on the contrary saying that, oh, this is not needed. There is hardly any patient who has the insurance. But now, whenever the ready cash is going to be lacking in the people's pockets, this insurance, those who have insurance, will always come in handy. For ophthalmic surgeries, you are aware that unless the policy is in force for more than 1 year, usually they will not give any reimbursement for the ophthalmic elective surgeries. So it is always better we tell the patients also to get yourself insured, so that whenever you require problems, this kind of economical problems will be less because you are insured. As of today, realize that survival for us is important, and survival for the patients, economical survival, is also important. Once you do that, profit and recovery will surely follow. So there is no reason for us to get depressed. We will recover. We will go with a much better boom in the economy, provided we survive at this stage, whatever is happening and whatever we are trying to achieve. Thank you for your patient hearing, and my special thanks to Advocate Dr. A. Deshpande for taking out this important topic. And this Consumer Act, what he has shown us in his lecture, probably is quite threatening, and I think we should learn it. I remember only one thing when I say that ignorance of the law is never taken as excuse for any wrongdoings which have been occurred in your hospital. So we must learn from him as well as from everybody else to see that this kind of knowledge must be dissipated to each and every member of our society. Thank you, Dr. Deshpande sir, and thanks for my colleagues. You are not unmuted, Deshpande sir.
So thank you, Dr. Kulkarni.
Yes.
And you have quite nicely explained how to come out of this situation, because this was unexpected situation which was lodged upon us on a medical profession, which caused the medical profession to go down a lot, and to come up out of it is a very difficult. Now the second wave is expected. How much it is going to do the damage, we don't know. Whether the third wave is there or something, or what else is going to come there, we don't know. But this COVID has definitely taught you how to come up when you are down with, and Dr. Kulkarni has said, given the ways how you should come up when you are down. And so I thank you very much, Dr. Kulkarni, for giving me such nice guidance, and to all our members that how they should come up in such a big disaster condition. Now I will request Dr. Prakash Marathe to give his lecture about Prakash Marathe. Everybody knows he is a past president of the Maharashtra, and honorary secretary Social Security Scheme IMA Maharashtra State, past honorary joint secretary IMA Maharashtra State, past president Indian Medical Association Pune, convener National IMA Headquarters New Delhi Standing Committee Prevention of the Diabetic Retinopathy Blindness, CWC member National IMA Headquarters New Delhi, Managing Committee member All India Ophthalmological Society, past president Maharashtra State Ophthalmological Society, past president and advisor Pune Ophthalmological Society, and the member and of the standing committee of the legal cell. He is with me in the legal cell. So with all these stars on his coat, I request Dr. Prakash Marathe to talk about the changing trends practice in the practice in COVID era. So he will say that what changes are going to happen and what changes are there. And I request here Dr. Prakash Marathe.
Hello, good evening, sir. Thank you so much for the wonderful introduction. I don't deserve that much. I think let me share the screen. Is the screen seen?
Yes, sir.
Yes, you can share the screen.
Yeah, is the screen seen?
Visible?
You have to start the slideshow, sir. Slideshow.
Yeah. Can you see the slide now?
Yes.
So I am thankful to Maharashtra Ophthalmological Society for giving me this opportunity, and thankful to our chairman, Dr. A. Deshpande sir, our stalwart past president, Dr. Anil Kulkarni sir, Dr. Neha Deshpande, and my colleague, Dr. Viral Shah, and the audience. I think this is the era of COVID, and in this COVID era, most of us have just started one thing. And when discussions were going on, it was the saying, you should keep one thing in mind, just survive in 2020. See, this is very important. Survive. Sir, mute kara sir. Deshpande sir, tumse mute kara. So what I said, that you should survive yourself in 2020, and not only yourself, but your practice. I think that is the basic need which was there in 2020. With these minimum expectations in your mind, probably you should be satisfied, you should be happy. So about changing trends in practice in COVID era, my previous speakers, they have talked about on this issue, that when COVID has hit, what changes they have made in their ophthalmic practice. And these changing trends are very important to survive in this COVID era. What were they? I think online medical checkup and consultations have already started. Now see, because of COVID, patients were not coming to hospitals. They were not ready to meet you. Even doctors were not ready to meet the patients. And online medical checkup and consultations, that concept which was not there in the past, has started in this COVID era. So what I say, take this as opportunity to project and promote your practice. Otherwise, it was not there. Now it is there. Basically, take this an opportunity. Accept this with positivity. Don't feel that your practice is going down, but find out some ways how to face this situation and how to take your practice ahead and ahead in the positive manner. whenever the patients were seen online on WhatsApp and various online platforms, this thing was lacking, and you shouldn't be lacking this particular thing, that is medical record keeping. Even if you are checking the patient online, you must keep your medical records perfect, because that is the thing which is going to save you in future. And whenever some medical legal aspects they arise for this, because this is the online consultation. In the past, there was one case, Dr. Pavaskar's case in Konkan. Because that doctor gave consultation on telephone, that was the online consultation, the court was quite created some issue on that particular thing and said that he should be penalized for that. After that, this COVID era came and courts started saying that you can do online consultation. So you can take this challenge and accept this online consultation issue. Next thing is, when the patient feels that he has not visited the hospital, he has not come to the consultation, why should he pay? But don't forget to charge your patient. In this COVID era, without hard cash, I think online various options were there. That is Bhim app, Google Pay, various online options. And you can work on this particular issue. But don't forget to charge. Of course, when you are charging, you are answerable to your treatment and for future follow-ups also. Because of online consultations, patients were reluctant to come to hospitals. But some type of patients, they must come to hospital. That was the issue. And in that case, protective gears to be used for direct physical consultations, and that was must. And of course, that was increasing your cost. In this COVID era, government rules and regulations were quite tough. Doctors were thinking that if they don't see patients, probably they will be safe. Few of the OPDs and hospitals were not working, but still, many of the doctors, they were putting themselves in danger zone. Few of the doctors, they have lost their lives also. And one important thing is, there was insurance for doctors, and that 50 lakhs insurance was given to government doctors, and private practitioners were denied for this 50 lakh insurance. This is the demand from our associations, like Indian Medical Association, that our medical fraternity doctors, those who have lost their lives, must get this 50 lakhs insurance. So what the condition says, what today's scenario is, so make use of social media, like WhatsApp and other online platforms you must use for your online consultations in this COVID era. These 2 to 3 things are very important nowadays, being discussed in various conferences. That is use of teleophthalmology. Mobile apps have been designed by various paramedical and medical legal companies. Artificial intelligence, and these things must be promoted. Whenever you are sitting at your place, so you should involve family physicians. Suppose you are general ophthalmologist, even family physicians can be kept in the chain. Suppose you want to refer to these patients to some super specialists, that is VR or cornea or glaucoma, even those reports can be sent online to these super specialist people. And this way, general ophthalmologist can get connected to various doctors in his profession. So you should motivate your patients and their families and society at large for this particular online business in this COVID era. And this way, your practice has been changed. Patterns of your practice, they have changed. So what you have to do? Make use of available optometrists, paramedicals for taking online pictures of the patient. Sometimes you are supposed to send pictures of these deceased patients to various higher centers. So make use of these paramedicals and optometrists. Fundus photographs can be taken. Various reports are to be shared by tertiary centers, higher centers for proper interpretation. Suppose you are a general ophthalmologist and you have to show that report to VR surgeon or some cornea specialist. They can see these reports online, they can see these pictures online and can interpret, and that way they can advise you, suggest you various options of treatment. So involve various super specialists for interpretation and further management. That is the important issue. And take this opportunity to train, to educate your patients, their families, and society at large. So you have to arrange for online social awareness programs. In the past, there used to be various camps, medical checkups, and various lectures. But this is the era when these things are not possible. So you can use this platform of various webinars and educate your patients and their relatives. And I think these changes are needed in today's scenario. I hope most of you have already started doing this. If not, take this opportunity. And I think with these words, thank you so much for all of you for the patient hearing. Thank you so much.
Thank you, Prakash. You are turning out to be a really great leader as far as not only ophthalmology is concerned, but your medical legal as well as social commitments which you are doing. And whatever you showed us actually is really worth seeing and repeating, because that is something where everybody is going to face and we have to come out of these problems. So thank you for your guidance and whatever you have really shared with everybody on the MOS platform.
Thank you so much, sir. Thank you.
Now we come down to the last lecture from Dr. Viral Shah. He was the past president of Nagpur Ophthalmic Society. He is the secretary of Vidarbha Ophthalmic Society, or VOS, and he was a chairman scientific committee for the Vidarbha Ophthalmic Society. He is at present also president of Lions Club of Nagpur. So he's a proficient eye surgeon as well as has a social angle to his work which he is doing. And he is also active in all his associations in the Nagpur as well as Vidarbha area. So we welcome Dr. Viral Shah and I request him to start his presentation. Dr. Shah, please.
Thank you. Thank you, Dr. Anil Kulkarni, sir. Thanks to the scientific committee of Maharashtra Ophthalmic Society to give me this opportunity, and special thanks to Dr. A. Deshpande, sir, Dr. Prakash Marathi, sir, and Dr. Neha Deshpande, my co-faculties for this webinar. My screen is visible to all?
Yes, yes, it is visible. Yeah.
So I have been given a new topic by Dr. A. Deshpande, sir. I am very thankful to him. It is a recent only, we have all hearing about this MSME. What is this MSME? MSME is micro, small and medium enterprises. And it's a very long topic and it's a very deep topic, but I will only be touching some highlight points which are beneficial to us as an ophthalmologist and doctors. So this MSME Act is an old act. It's from 2005 and it was enacted in June 2006. And its main aim is to facilitate promotion and development of small and medium enterprises. It is governed by MSME MSME Ministry, and the MSME Minister right now is Honorable Shri Nitin Gadkari ji itself, and he has brought about many dynamic changes in this act and made it very user friendly. So I will just touch upon some of the salient features. Yes, the board is created and all that. This you can go through. I will just touch some highlights. So whether it is applicable to us or not, the MSME is divided broadly into two categories: manufacturing category and service enterprises. So manufacturing category, also some doctors are using it for some their optical manufacturing. It is for a limited purpose, but service enterprise, yes. Service enterprise, yes. Each and every healthcare sector comes under service enterprise, and all doctors are welcome to get registered into MSME. So can doctors take registration under MSME as per MSME Act 2006? Yes, MSME covers manufacturing as well as service sector, and yes, doctors can take the benefit of MSME registration. Why to take and what are the benefits? That's what I am going to highlight in very short. So previously it was micro, small and medium. The definition changed with effect from 1st July of 2020. Now if your investment is less than 1 crore, you are micro. Your initial investment is less than 10 crore, you are small. And if it is less than 50 crore, it is medium enterprise. So what is the use? I will come later. Udyam registration was also started. What is this? It's just like an Aadhaar card. It's the Aadhaar card of your business. So all are requested to get yourself this Udyam registration done. This is going to be a very key factor in your practice in future. If you have Udyam registration, you will be able to scale up higher and higher as early as possible, and as you will become very flexible and you will be able to comply with all government norms. So you must get Udyam Raji. It is very easy to get. It is online. You don't even require a consultant for this. You can go on the website of MSME Enterprises or the Udyam direct. You type it Udyam, you will get the site. All you need is your PAN card and your Aadhaar card. Bank account, if it is there, it's okay. If it's not there, you can even get Udyam, that is Udyog Aadhaar card memorandum, right? So
What is problem? You are not being heard. Are you able to hear him? Hello?
No, sir. No, we cannot. We can't hear him.
You are able to hear me?
Yes, sir. Yes, sir.
Dr. Viral.
Yeah.
Now you are audible, sir. Unmute yourself. Unmute
Now
yourself.
it is okay.
Yeah.
Okay.
Yeah.
Continue.
Right, sir? Now I'm audible, sir?
Audible.
Yes, yes.
Yes.
Now I'm audible, sir?
Yes. Now you are audible. You can continue.
Hello?
Yes.
Dr. Viral, you are completely audible. You can continue your talk now.
If you are a new practitioner looking to set up, you can get a mini bank. If you are a new doctor or a new practitioner, you are going to start. Sir? Hello?
Yes, you are audible. Completely audible. Continue.
You can off your video.
Yeah.
You can off your video and you can start the presentation.
Okay,
Continue
sir.
the presentation. Put your video off.
Okay, sir. Yeah, I will do it, sir. Yeah. So if you are a new practitioner or you are starting a new center, then you can scale up. You can go to any bank, apply to any bank, private or national. Everybody has got a target from the government to provide loans under MSME Act. So the rate of interest is very low. It is 2% less than whatever the current market rate is. So they have to give, the bank has to give from 2% low interest rate. It is for a 5-year period. For the first year, you don't have to pay any EMI. The EMI starts from the month 13 and it ends at the month 60. So you have to pay in 4 years after the completion of your first year. Also, this loan are without collateral, so you don't have to mortgage anything or to take a guarantor or anything. Just your degree of proficiency. So it's a boon for a new practitioner looking to start this equipment heavy field. So as our field is very equipment heavy and the initial investments of subspecialists, they require lots of equipment, so they can always apply easily. Second, also, if you are already having some existing loan, you can also apply in this MSME scheme, and the 20% of your outstanding loan can be converted into MSME loan. So you can scale up from that, or you can reduce your burden EMI. And various stimulus are given from time to time. And also, if you want to start manufacturing, doctors are now procuring their own medicines and marketing. They have got a pharmaceutical license. They are marketing out themselves, and they are directly selling it to the various outlets, and they are reaping the benefits. So there are many benefits. You can go into details. Always consult with your chartered accountant or your accountant or your lawyer. But benefits are going to increase day by day, because government is giving more and more stimulus into the MSME scheme.
I think there is problem with your internet connection. Viral. There's some internet connection problem.
If they are
Connectivity problem is there.
started practice or they are trying to practice or to scale up, they must into the once MSME on with their they are already into the priority classified as a priority sector. Health is classified as priority sector. So people are very yes. Now I'm able to. You are able to see, sir.
Yes, is able to see, but problem in the internet
Yes,
connectivity
it is
and voice is
coming
cracking.
message
Voice is
that there
cracking.
is a connectivity problem to the Viral Shah.
Okay, okay. So I will just highlight it without a.
Yes,
Yeah,
yes.
yeah, please.
Yeah,
Without a
fast.
PowerPoint now.
Yeah.
So scheme, each and every ophthalmologist must go. The newcomer must go for it. And if you are looking to start a new center or scale up your practice, suppose from a small setup you have started, now it's 5 years, 10 years, and you want to go up to a bigger project, you must go in for this MSME option. You must consult your lawyer or a chartered accountant, and they will tell you the nitty-gritties, but you will find in the end that it is a very good option. And as the government is giving more and more stimulus, provides stimulus on various periods, so you will find this scheme is more and more beneficial. Right, sir?
Audible.
Yes, sir. So that is my take-home message, that everyone must get registered under MSME, and they should start taking advantage of this MSME scheme.
Thank you, Dr. Viral Shah. Actually, this is a very new concept and a very nice one by which you have put it. Sorry for the trouble and unstable connection. So some of the things were lost. But I think you have given a food and thought for the people to think about it. With the present scenario, if you can get some amount of additional help through any schemes, including the banks, obviously it is welcome. So I think our members will also feel it much nicer.
These loans are yes, sir. These loans are without collateral, without mortgage, and without any guarantor required. Just on your basis of degree, the government is providing you the loan. So that's a very good option for middle class or lower middle class without any backing to start a setup.
Okay. No, that option will probably be required by higher middle class also. So you don't have to bother about it. May I now request Dr. Prakash Marathe to take any questions which are there?
Yes,
because
sir,
I think
sure.
we have crossed our required time. We have to vacate.
We can take couple of questions.
Yeah, couple of questions you can take, and yes.
Yes, if anybody on the panel or whoever is the faculty over here can ask some of the questions if they have in their mind. Dr. Deshpande sir, may I ask one question?
Yeah, please.
About this 50 lakh insurance. What is the 50 lakhs insurance to the private medical practitioners, which was not sanctioned by the government? What is the present scenario? Are we in a position to get this for medical fraternity? 50 lakhs insurance from government?
50 lakhs insurance can be taken as an individual. Also, individual insurance premium will be 46,000 or something, 600 or so. It is a very huge. For ophthalmologist, for 50,000, if it comes in group insurance, it is only 30,000, 3,200 something. So it is tremendous less in group insurance, which we have installed at present. So any ophthalmologist, if he wants, he can join the group insurance and have a benefit of less amount of premium. But if individual he wants himself to be individual insurance, then it goes to about 46,000. Yes.
Thank you, sir. Thank you.
I think, sir, probably Prakash wanted to talk about the COVID insurance, which was declared by the government.
Yeah.
And Prakash, sir, what has happened is that the authorities, district authorities, have to certify that you were working in a COVID facility where you were assigned the COVID duties, and the facility was the official facility by the management. And that is how the district authorities are not willing to give this certificate to the private practitioners. So unless you have actually worked in the government or designated COVID facility, with a written letter from the collector or the commissioner, then only you are eligible for this 50 lakhs insurance. That is the situation today.
Yes, sir. Perfect.
Yeah.
I think in this COVID scenario, what one thing has been observed, most of the hospitals which were run by seniors, of course, not only ophthalmologists, but many branches like gynecologists or physicians, they have started stopping their practice. Even hospitals, they have stopped. Even consultations and other activities, they have stopped. This is because of there is so much of risk that was there. Then medical legally, there are so many problems. But one important issue is capping of charges of COVID patients as well as non-COVID patients. Recently, capping on charges of non-COVID patients, that has been lifted by the patient, means government. So you can charge accordingly. But probably because of these news which are printed in newspapers and government is trying to harass the medical fraternity, they are trying to cap. So everybody feels that whatever is charged by the doctor and hospital is very much costly, and they are always trying to argue. So bill is not at all justified by the patients and their relatives. So that is the unfortunate situation.
Yes, sir. Marathe, sir.
Yes, Viral Shah.
Marathe, sir.
Yes, sir. Yes, sir. Bolo.
Yes.
Yes, Viral.
You want to say something? Viral Shah. Okay, continue, Marathi, sir.
Sir,
no, I think
the government has not lifted the.
There is a connectivity problem with you.
Okay, we cannot hear Viral properly.
Not
I think
lifted the capping. The court has given a stay order and the capping charges for non-COVID patients.
But still, the problem is there. In the past, suppose 10 to 15 years ago, there was no interference by the government or government officials,
yes, sir,
or government servants for that matter. But nowadays, which was the restriction for government hospitals and government doctors, it was not there for private practitioners and private hospitals. But nowadays, probably all the patients and relatives, they are trying to ask the questions to all medical practitioners who are in private sector. And this is unfortunate situation. There are countries, European countries, American countries. In these countries, probably because of insurance and because of government policies, medical treatment is free for the citizens. So they are not that way worried about medical charges. Here in India, India being the poor country and medical sector, whatever private setup they have formed, probably it is so costly affair, they have to charge something to the patients. But what patients expect from the medical fraternity is cheaper treatment, free treatment. And this is the unfortunate scenario in today's scene, if you see, because everybody is expecting it is at the lower cost, which is not possible, because costing of so it is like a small scale industry. To run the hospital on a bigger scale is not easy. ICU beds and cost of the equipments, cost of the treatment is not less. But how to run the hospital is the problem nowadays. I request Dr. Anil Kulkarni, sir, to throw light on this issue.
Hey, sir, basically what you said is correct, but the feeling about this overcharging actually came from the treatment given by the corporate hospitals. And because of their infrastructure requirement as well as their relationship with insurance and governments, they could get away majority of the times with a very high charges, which were unacceptable to the general people. And whenever somebody in private practice as a solo practitioner started asking for what is right, is requirement, people started equating it to the feeling that this is something which are definitely high. Another thing we realized is that whenever there is a failure of the government machinery or the health authority, then it is easier to direct the anger of the people to the private practitioners rather than finding out the reasons why they have a problem. See, if you really manage your civil hospitals and primary health centers properly, as had happened, supposing in our Sangli district also, the collector was very proactive in setting up the different facilities as well as giving an assurance that, okay, whatever you are doing, we are there behind you. And he employed people at every hospital to see that the things do not go out of hands. But how many people are interested in this proactive approach? Whatever I say should go. and the people are at large. And see, most of the times people do not have that kind of money to pay. That is what I was talking in between, is that it is their survival and it is our survival also. So somewhere there has to be a balance between the requirement and what is true for it. But as you very rightly said, that because the patient pays from his own pocket, that is where the exact all problems come. And if they more and more people get insured, probably half of the problems will be over. Sometimes when I started asking this 20 years back, people were thinking whether one of my relatives has become an insurance agent. So what can we do? If you give a good advice also, then it is twisted. But then this is high time. And the second one is a group practice, which we try to do since many years now. A solo practitioner to face the problems and to get this type of financial problems is going to be more and more difficult. And then people like A. Deshpande is going to get continuous calls because of the disputes which are occurring between doctors and patients.
Sir, I have a question, sir.
Yes,
please. Yeah.
Sir, actually, the NABH guidelines are every patient for the cataract surgery has to do HIV testing and hepatitis B testing also. So, in addition to that, if we suspect COVID now, the COVID testing is also to be done. So, can we, in this COVID era, can we skip all those testings and only blood sugars and a physician checkup will be sufficient for posting the patient for the elective surgery?
Basically, NABH doesn't give you this kind of guidelines that these are the particular tests which must be done. So that depends on your inspectors, who can probably tell you this is something which is required. But there is no written guideline as far as that is concerned.
NABH doesn't
Second
require
thing is, if you are doing a NABH under HCO or SHCO category, then these rules apply to a larger extent. Please try to shift to the ECO category, which has been specifically given for the eye hospitals. And then all the standards and the requirements are much less, and probably they are more applied to our ophthalmic hospitals.
Okay. Now, the next point I want to add here, probably we are coming to the end of the session. Because of the violence on doctors and medical fraternity, this issue is coming up. And it is quite harsh nowadays. Three things we must tell to our audience here. That is doctor-patient relationship, which was very nice in the past. Of course, it is good even in today's scenario, but it has to be polished in a proper way. Should be included in the medical curriculum. Number 2, about ethics. And number 3, about medico-legal lessons, which should be included in the syllabus of our MBBS course. And I think that is the need of the hour. With this question, I request Dr. Deshpande sir to talk a little bit upon this and sum up and end our symposium.
Thank you everybody for participating in the symposium. And I thank all the people who are listening us and giving their opinions or questions. I thank you everybody, and thank you also the people who have arranged this and who are conducting this. So thank you very much, and we will come to an end of this session.
Thank you.
Thank you, everybody.
Thank you. Thank you. Thank you.
So if anybody has questions, you can call directly to all the faculty in this medical center. Thank you so much. Thank you, Dr. Deshpande. Thank you, Dr. Neha. Thank you, Dr. Guru.